Let me know clear and audible. Okay,
Yes,
so
hi.
okay. So I welcome you all to today's class. We are having our first class of the clinical session, the clinical batch, and I hope that your journey with us goes really well and smoothly. So let me introduce myself. I'm Dr. Iqra Ahmed, and I have done my FCPS from Pakistan, and I have also done my MRCPCH. I gave my clinical exam in Pakistan Center in 2023, and since then I have been involved in teaching. And I have been, I think I can see a few names of the students that have been in my AKP group as well. So I welcome you guys too. I've been associated with teaching for last 1.5 year, and so like starting this lecture. So let me just tell you that okay, someone has messaged. Dr. Amber has messaged that she is unable to hear me. Can rest of you confirm that is my voice clear or is it not?
It's clear.
Okay, thank you so much. Thank you, Dr. Tajana. I'm really glad that you uh always message and respond. Okay, maybe I was a bit speaking a bit slower. I'll be louder and clearer. So the pattern and the format, basically, you know that the clinical exam is an interactive exam. It's a face-to-face. So that's why what we want from you, the participants, the students who have enrolled for our class. I have a list of names of all of you. So if you can just write your names in the group, those who have, because this is our first lecture, and I know that a lot of uh, people have joined in because we wanted more of you to just have to just attend this introductory lecture. So just message in the group whoever from the candidates who have registered are in the class. The format is going to be that for today, because it's a first class, first I wanted to give a detailed introduction of History Station, how to prepare for it, what comes in it. So it's going to take maybe around 1 to 1.5 hour. So in the first part, we'll be discussing about the introduction and everything. And in the second half, we are going to have interactive, like we'll be starting with the histories. CNS histories. Initially, I know that the schedule that you guys got had one class involved in which the history of CNS introduction was combined. But I felt that that is not enough because we want to do the CNS histories in detail as well. So we'll have divided this first class into two parts. So today we are going to do the introduction of the history station, all of its details, whatever questions do you guys have. And after clearing that, then we are going to move towards the history of headache, and I will be needing one participant who's going to actively participate and do the history station. And we'll discuss that. And the second part of this session, CNS histories, it will be done on Tuesday. So you'll get a link about that as well. Please let me know whoever from the enrolled batch is present here so that I can know that who's going to be presenting later on. Also, please do not be hesitant in, even if you are a beginner, you have never ever practiced before. I think you should definitely give a try. We are going to give opportunity to each one of you because from my personal experience and from all of those who have who have been given exams, they always say that active participation is much more important than the passive listening. So no doubt, obviously, if you're just listening, you are going to learn and have an idea of things as well. But if you're going to participate, even if you're doing it, not doing it like perfectly, but that's gonna help you, and that's really gonna make your track right from the beginning. Like it's you're gonna be on the right track from the very beginning. So I think we have quite a number of participants, and I was just waiting if we could have more participants so that we can say. But obviously, these are going to be recorded lectures, and a lot of the participants are going to have these to listen these later on as well. So let's just start with the history station, its instruction and everything. If at any point you guys have any question, feel free to just ask. I do not want it to be a unidirectional or one-sided teaching class, because unlike the written classes, because in the written classes it's like always I'm just speaking and speaking. In this one, I really want you guys to be interactive, give your input. Maybe just don't like you guys don't open all the mics at once, and just raise your hands if you have any question, any queries, and maybe just write in the chat box as well. Okay, so the more interactive the class is, the more beneficial it is going to be for each one of you. So let's start. Okay. So, starting with what is the timing? I know some of you, I'm gonna take these things from the very basics. Okay, so considering that all of you need to know each of the details. So starting with how the history station goes on. So you know that each in so first, okay, before starting this, let's have like a journal look on how the clinical exam is. So the clinical exam has 10 stations. There are four clinical stations. There is one development station. One to four is the clinical station. Fifth is development. Sixth is the history station. Seven and eight are the communication stations, and nine and 10 are the video stations. Okay, so for each station, the exam is assigned in such a way that each station is in a different room. And before going to the station, you have some waiting time outside in which you are provided with a paper and a pencil in which you can write things and make your flow chart or something. And then you go inside the station and then you complete that. So what happens is that in this history station, you can see that 4 minutes are given outside. Candidates read the candidate information sheet. You'll be given a sheet in which your role is being written, that you're a pediatric registrar or whatever your role is. The setting will be given, that are you taking the history in an outpatient department, or is it in a ward? Is it in an emergency side room? Any of it. So it's important to have a read on that. And in the so you have 4 minutes for that. So we're gonna discuss later on that how can you utilize these 4 minutes and what do you have to do in these 4 minutes. So at 4 minutes, the candidate enters the station. Then the history taking is for 13 minutes. Okay. So the examiner introduce self and the role player. So you have all your exam sheets in your hand. Okay. You're given a folder in which all the exam sheets, like your marking sheets, are given to you. So when you go inside, there's an examiner and you give your exam sheet to the examiner, and then he introduces himself, and then he asks you to start taking the history. Examiner provides introductory statement very briefly if that's required, and then he asks the candidate to take a focus history. Can you start taking the history? So at 9 minutes, there's a bell. So it could be a bell, but usually there's a knock on the room or any of, like, you will be informed basically that 4 minutes are left. Okay. So you see that history is for 13 minutes, and at 9 minutes, you're going to hear a bell or a knock or any intimation would be given, and you will be knowing that 4 minutes are left. That's important because you are not going to have a watch or something ideally in the exam station. So you need to practice from the very beginning in a way that you know that I'm going to complete my history in 13 minutes. And once you know that it's 4 minutes, so you can just wrap up things. And like if you are being late, if you have not done a lot of things previously, so you just start doing things a bit quickly. At 13 minutes, the helper announces that it is end of history taking. So once the history is over, the role player that who is sitting, who was going, like, giving the history, he or she is gonna go out, and then you're gonna face the examiner. And for the next 9 minutes, you're going to be facing the examiner, who is going to ask all the questions. So the candidate discusses the patient problems with the examiner. Then helper again warns at 3 minutes, but that's like not really important because the things keep on going on. Candidate discusses the management planning with examiner. At 22 minutes, the helper announces that the station is over and the candidate moves on. So this history and the development station, these are the two big stations in the exam, which are 22 minutes each. And it's a long time, and it's really hard. Like at times, it's really hard to uh, like go through these 22 minutes. So what's going to happen is that at a time, that one circuit has 10 stations, and at a time 12 candidates are giving the exam at one time. So basically, history station and the development station are running side by side. Two stations are running side by side. Usually, it's the same case that is given in both the red and blue. The one circuit is mentioned red and one circuit is mentioned blue. So both of these have the similar histories. Recently, I got to know that in one exam, there was a bit of a difference in the history, but I think that really doesn't matter. So you need to know that this is going to be a long station and this is the time division. So when we are going to do it in our practice sessions, in our classes, we are going to do it exactly in the same way. I'm going to give you 4 minutes for the preparation, then the 13 minutes for history. I'll be telling you in between that 4 minutes are left, and then last 9 minutes for the discussion. Okay. So now moving towards that, what is the aim of the history station? Obviously, in the exam, they have put each
Can
station.
I, I'm sorry, can I ask the previous slide, please? Thank you. Okay. You're explaining very well. Thank you so much, Dr. Iqra, like always. I want to know. You said before you came in the examination room, so we are given one paper and pencil. Can we put on that paper and pencil um, information from the candidate information sheet from the outside?
Okay.
Can we
Yes,
write
yes, yes. Okay, just complete his question. I'll answer.
okay, just that I want to ask, do we take this candidate's information sheet, or we can write on that paper informations from the candidate information sheet before we go in?
Okay.
Thank you.
So you're given the candidate information sheet is a laminated paper that you're given outside, and the paper and the pencil that you have outside, that is for you to write anything that you want on that paper. That is your paper. Okay, so you have to write all the like you because in the history station, usually the stem is not really long. They just usually the question is something like that: the child is having headache for this amount of time or something like that. So there's a very small information that's given outside. So yes, what do you have to do outside is that you have to write the name of the candidate, the name of the role player, the mother or father, whoever he is, and then you have to make any of the notes that you want to make. And then you're going to take that paper inside with a pencil. And obviously, when you are taking the history from the role player, then you can always write on that paper. That is your paper to write on. You can write anything on that paper that you want, right? You're allowed to take that inside and write anything that you want. So I'm going to tell that in more detail in the later slides how to utilize the 4 minutes that we have outside. Okay. So that will answer your question in further detail.
Yes, thank you. I just wanted to know if we must go with the empty paper inside, or we can go like basic information, like name of the baby
Yeah, you
or
have
name
to
of the
write the
mother,
name. Yes, you
you
have to
know?
write the name of the mother of the child and or any of the important thing that is written outside that you think it's important. So you can write anything. In fact, you should
Okay.
write the names because what happens at times is that you forget the names and it's
Yes,
really a
because
bad
of
mistake.
that.
Yeah, yeah, you should write the name. Yes.
Okay, thank you so much.
Okay, so moving forward, that these slides that I have taken, these are from the RCPCH websites, and why is this history station? What is the aim of it? So let's just read that in a bit of a detail so that we know that what are they aiming, that what are they going to assess us for. So the aim of the history station is to assess that the candidate can take a focused history, can summarize the main points, and integrate these to come up with a diagnosis or differential diagnosis. Candidates will then need to prioritize any necessary investigations and formulate a management plan. There will be a role player in the station. Station is based on a centrally written and benchmarked scenarios. Each scenario is based on a child or a young person who could have a new diagnosis. For example, epilepsy, headaches, joint pains, or a specific problem with an already established diagnosis. For example, weight loss in adults or diabetes in children. diabetic child, feeding problems in a child with cerebral palsy, etc. The candidates will not be required to examine the patient because there's no patient in actual thing. Relevant information, including the growth charts and results of investigations, will be provided where necessary. So, because in certain exams, candidates have to take the growth chart with themselves, but in this one, you don't need to take anything with you. The focus of this station is to test the candidate's ability to take a focused history on a child or adolescent's current problem, summarize and recognize the main issues, and discuss their management. It's not a test of the ability to take a comprehensive history. Candidates are unlikely to be asked to repeat the whole history as the examiner has just witnessed this being obtained. Candidate information, what have they written here? Let's just see. So each candidate will be provided with a candidate information sheet that describes the candidate's role. As I already told you that either you are pediatric registrar, usually it's a pediatric registrar, or there could be any other role like ST3 resident or something like that. The clinical background and instructions. At times there's things are given like that the child has been referred to you by the GP and some information about his previous medication or some things are given. This is to be read before the start of the station. It is often in the form of a letter to the candidate asking them to see the parent or the adolescent. Candidates will be expected to take the history from the role player. If the role player asks question during the consultation, it may be appropriate to answer these. Which means that when you're talking and if the role player is giving some concerns, then it's not that you do you have to clear the concerns and show empathy and then move forward. The examiner will then test the candidate's knowledge of the issues raised and the management plan. Okay. So, uh, okay. At the start of the station, the examiner will introduce themselves and the role player. The candidate is then provided with the task. The examiner will then observe the interaction between the candidate and the role player. Candidates will be expected to manage their time appropriately in order to undertake a focused history. Examiners might move candidates on if they are taking too long on a particular task, so they are able to discuss the next elements of the station and award marks for each domain. If a candidate has reached the end of the history taking with role player prior to the end of the time allotted for this, they are not permitted to move on to the next element of the station, which means that you are given 13 minutes for the history. And if due to any reason, like maybe you have missed some things or you have done really fast and you are able to complete your history in 11 minutes, then you will have to wait for the next 2 minutes till the bell is rang, and then you will be able to start the answering. The examiner is going to ask the question further on. Usually it does not really happen because the history is a long station. There are so many things to ask. So there's hardly ever a chance that you're going to do it really, really early. But at times, if you do that, then you'll just have to wait, and the discussion is going to start after the 13 minutes are completed. Introduction, like as already mentioned, the scenario will include some background in the task to be completed. Hints and tips. Upon receiving the instruction on the task for the station from the examiner, candidates are advised to request clarification of any part of the task that they do not fully understand. So basically, this means is that when you have gone inside, and if examiner has told you anything, usually the in the history station, all the information is given outside, and examiners do not really tell you things inside. This is usually more applicable in the clinical stations in which your command is being given inside the station. But here, if the examiner tells you anything, like if any edit information, and you're unclear that what has the examiner said, then like take then just ask it again in the beginning of the station, right? Rather than just getting confused and doing the things wrong. Examiners are looking for a focused and a structured approach to history taking. This should be no different to what is undertaken in the clinical practice, but to properly prepare, candidates should embrace all opportunities at the workplace. Standards, the candidates are expected to demonstrate the clinical skills and knowledge expected of a trainee ready to progress into level 2 training. So all of this means that, see, they're writing again and again and again that a focused history, which means that focus basically means that whatever problem the child is having, you need to pick those problems out. You need to find the, if it's an open kind of a problem, then you have to discuss like all the possible, like you have to take a history so that you can rule out all the relevant differential diagnosis. It's not necessary ask each and every irrelevant thing if that you think that's not important. Okay. Obviously, when you're gonna do it in detail, that how do we have to proceed with the systemic review and everything, you'll gradually get to know that if in at any point you are running out of time, then what's more important to ask. Like I always say that if you are running out of time and you have a lot of history to cover, and you're like there are a lot of things like nutrition development, all of these points are being, they have to be done, then it's important to maybe just skip these and do the psychosocial and the family history first, because in the cases in the RCPCH exams, the social aspect of any disease is really, really important. It's not that just what's the organic problem with the child. You do not really have to only treat that. You have to manage any of the problems that the parents or the child is facing at school, in the community, or like in social interactions, any of those things. Okay. So this, like, yeah. So this is how it goes. Then the history station, it is marked, it is of 10 marks. The total exam of the total clinical exam is of 82 marks, in which each station, each clinical station, the first four clinical station is 8 marks each. Development is the biggest station, which has 12 marks. History is the second biggest station, which has 10 marks. Communications again have 8 marks each, and the videos have 6 marks each. So the history station is for 10 marks. The MRCPCH exam is a really structured exam in a sense that they do not just really give you, they're not judging you as a whole and gonna give you an amount of number from 10 by just having a journal ID about that. Each mark that you are being given is given according to your performance. And as you all might already know that in the clinical exams, a lot of our clinical skills are being checked, okay, from your gestures, from your communication styles, to your management planning, to your understanding of the things. So you are assessed according to different bases. Okay. So for the history station, these are 5 domains in which you are assessed. So like you can see that it's 1, 2, 3, 4, 5. So each domain has 2 marks. Okay. So if you're gonna go do well, at times it happens that you're not able to take a proper history, or you are not or maybe able to give proper management, then it doesn't mean that your whole station is gonna get upset, like it's gonna get like marked negative. If you have done good communication, if you have taken history in a proper way, you're gonna be marked for that, and your marks are only gonna be cut for the management or anything that you have missed. Okay, so let's just read that what are the skills that are being assessed. So A1 that you see is information gathering and the history taking. These are the things that you are judged on. Asks key relevant questions. It sensitively gathers appropriate information, explores main problems, concerns of role player in a structured manner. So you see that you have to ask the relevant things in a structured way. If you do that in a well, then you are going to get 2 marks in this domain. Okay, so you see that you can either get 2, you can either get 1, or you can either get 0. Okay, so this is how you are marked. So see, for each domain, maybe I don't have that in this one. Maybe I'm gonna share it with you next time how the mark sheet look like. But you see, if you have done really well in the domain, you're gonna get 2. If you like are okay, maybe in the clinical reasoning, you're gonna get 1. And if you've done really bad in something, you're gonna get 0. And this is how your marks are gonna be calculated, and you're gonna get a final score. Also, after the exam, you do get your mark sheets to see that how are you being marked. Like if you're marked less, then the examiner has to write it down that what did you do wrong. So the second one is the clinical reasoning, in which there's a formulates and proposes likely appropriate differential diagnosis, understands the implication of the findings, able to suggest appropriate steps if the exam is inconclusive, right? Then in the V2, management planning, relevant investigations to appropriately address the identified problems, provides safe, ethical, effective management plan that relates to the parental concerns, including appropriate referral or escalation. So this point is really, really important. RCCPCH wants safe doctors. They do not want doctors who have a lot of information and they do not know when to refer. Okay, guidelines are really, really important for the management of the history, telling and the answering the questions in the history station. Why? Because you need to know that what is your boundary. You are not working as a full consultant, right? This exam is not for the consultant level uh, position. This is as a trainee. As a trainee, you should know that what things are in your domain, what things can you do, what investigations can you prescribe or suggest on your own, at what point do you have to involve your consultant, at what point do you have to refer the child to maybe a nephrologist, neurologist, any of the specialties. Okay, so what they want is not a lot of like they won't be expecting you to tell the drug dosages, right? Because you have like medicine charts, the BNF books for that. What they want is that what management can be given, like the immediate management, emergency management that has to be given. That's really important. What like early actions can have to be taken, and then when is the safe time that that the child has to be referred and not just lingered on. So this is really important. Whenever you're telling the management planning or anything, it should be in your mind, because if you are from the different countries and you have given specialization exams in your countries, like if I speak about myself, so in Pakistan, the FCPS that we have is like a consultant exam, and for that exam, we need to know each and every detail of all the possible managements, all the new advances, all the drug doses, everything. So we are being assessed for that in our exams. So what happens is that any of the candidate who has already given any of the postgraduate exams, and they are tuned to telling those things at a much higher level. I really like advise them, and I have to tell them that you have to come one step backwards. Okay, you have to come at back, and then it's not about how much you tell, it's about how effectively you tell things and how safe are you in telling things, right? Also, the second important thing is that it's not just about telling the medications, about the investigations and everything. It's about the overall management of the child, including the social help, including the psychological help, including the patient groups that you have to tell, like the support groups that you have to tell. This all of this comes in the management. Then the another domain that is assessed is the communication rapport and the communication style, which is like in which you are assessed that do you have an appropriate level of confidence, greeting and introduction, professional, sensitive, appropriate body language, responds to the verbal and the non-verbal cues, develops appropriate rapport with the role player, puts the role player at ease, clarifies the role and the shared agenda, appropriate tone and pace. So you see, this exam is all about communication. You are being judged about the communication in every station, in the development and the history. And it's not the communication is not just two stations. Communication is being assessed in everyone. So imagine that you are unable, your maybe your history station goes really, really bad, but you have been good at communication. You took the history good. You're not did not provide good differentials, but you took the history in a very good way. So you are going to be marked for that. Okay. So, one of the other things that I always tell the candidates is that this exam is about how you speak. What is your tone? What is your pace? Everyone has different like speed of talking. Personally, I'm someone who talks fast. Okay, so when I was preparing for the exam, it was a real challenge for me to just slow down, keep my voice low, and then just be humble and talk to the role player. That was a skill that I had to learn. So when you that is why I'm telling you that you guys need to come up and keep on practicing with us, so that it's not just about that we're telling you what knowledge is, that we are going to assess you, and we are going to tell you that is your speed right, how are you going to say things, how your sentences should be, right? All of these things are important. And then the last one is the verbal and listening communication skills. You see, again, this is communication skills as well. Applies active listening and displays interest towards the role player, allows other opportunity to speak, appropriate language used in challenging circumstances with any jargon explained. So you see, this means that history at times it happens is that the candidate, they keep on asking the questions. They do not let the role player speak or tell their concerns. So they keep on throwing one question, two questions, three questions, right? And then this is not a good communication style, because in the history taking, you have to look for the concerns of what the role player is going to tell. So all of these things are like how are you going to be assessed, and all of these things, all of these skills, we are going to teach you in like during our sessions, and we'll be practicing, and hopefully by the time you're gonna give the exam, you will be expert in that. Okay, so coming to
Can
how to
I ask?
utilize the,
Sorry,
yes,
but I would like to ask for the previous slide, please.
yes.
In the fourth box, communication skills. So, like you said perfectly, it's uh, professional, sensitive, appropriate body language, responds to verbal and non-verbal cues. So, are they already chairs for the examiner, for us, and for the role player already placed on the right place, or we need to go further or closer to the patient, to the role player? How it's going that inside? Because I heard that you don't need to be so far, neither so close to the role player, to be like to don't cross the legs, to be with straight legs, and to look appropriate in the eyes and all that stuff. So how is that positioning? How to do that right positioning there, please?
All right. Thank you, Dr. Tadana. Very nice
Thank
question. I thought of telling it, but I forgot. Okay. So let me just draw for you that how the scenario usually is. So yes, the chairs are already placed at their own uh, position. So imagine that this is a chair and examiner is sitting here. Okay. So here will be the role player. This is examiner. You go inside and this is examiner. And at some distance, there is role player. Okay. So this is your seat. So initially, you are facing towards the role player, okay, and you're having there's a specific distance that you don't really have to change it. Okay, you just have to sit there. At times there is a table in between, at times no, it depends. But usually there's a table on which like usually that happens in the communication station in which they like have like kept a water bottle or at times a tissue box as well. There could be a table, there could not be a table. So if initially you are facing the role player, you do not face the examiner. Okay. And this is about communication is going like this. Okay. And the examiner sitting here is just observing you. Once the history is being done, then the role player is going to leave. He's going to go outside and you're going to face the examiner. And then you, both of you, for the next 9 minutes are looking at one another and you're communicating. Okay. Regarding the appropriate body language, these are the things that you learn with time. Okay. Obviously we are going to help you with that as well, but you see that, okay, let me just on my video for that. So you see, personally, what my issue or what my thing is that when I talk, I use my hands a lot. I used to explain like this and things like that. But for exam, you have to keep things under control. Okay. So using a lot of hands does not seem good because it means that you're shaky. Then you see that because plus like why did I open my camera today was one of the reasons was that whenever we're going to do the history, we are going to me and the role player, they're going to open the cameras. I highly recommend that. If someone is really not comfortable sharing the picture, that's fine, but I do it because you see that it's important that how you're communicating. I'm gonna judge, like I'm gonna see and analyze that how you respond. So you see that if I'm listening to you, so I'm nodding my head, which means that I'm giving non-verbal cues. And then if someone is telling me something, I'm say, okay, something like that, which means that I'm acknowledging that. So these are the verbal and the non-verbal cues that you are giving. Okay. Along with that, yes, sitting is usually we say that you have to like don't cross your legs just because in that manner you have a paper on your lap as well. You just keep the paper on your lap. I don't really remember was there any thing to be kept under the paper. I don't remember that actually, but I don't think there's anything. You just have a paper and a pencil. So so you just like see properly close your legs and keep them. Don't shake them a lot. Don't shake your hands. Don't use a lot of like when we talk, we have certain pet words that we use. We recommend try avoiding that. Okay, like at times people say, I'm like that. Okay, something So don't use a lot of those words. And then obviously when you're talking, then you have to have a continuous contact. We do not recommend that you keep on looking at your paper and then you keep on writing on the paper. You have to keep looking at the role player. And then obviously we are trained enough. And that's why I want you guys to open your camera so that I can know that how much are you um, how much are you looking at your paper, how much are you writing. Obviously some things have to be written and that's why the paper is being given, but just write one or few sentences, maybe look for a second or two for downwards and then look upwards, that's fine. But if you're continuously looking downwards and you're writing something and you're not having an eye contact, that's gonna cost negatively on your marks. Okay. Okay, so moving forward
Thank you.
to, okay, all of you are
Excuse me,
welcome to
doctor.
ask
Uh,
questions.
excuse
Yes.
me, doctor. Doctor, one question. Do you shake hand with the role player in
No,
greeting?
no, we do not come in personal contact with the role players. No.
Okay, okay. Thank you.
Okay, someone has written in the. Okay. Okay, so moving forward. So this is how you utilize the preparation time. So I told you that you have 4 minutes outside the station. So how are you going to use that? First, write the name and age of the patient on your sheet. Okay, so you have the sheet. First, have a quick read of the sheet. Look at your role, look at the settings, look at the scenario. For the history station, I told you that the paragraph that's written, the information is not a lot. It's pretty concise. For the communication, on the other hand, you have a big scenario outside that you have to read. Okay, so we'll talk about that when we're gonna discuss about the communication thing. But for the writtens, you're gonna have like a small scenario outside. So write the name of the child, first thing, age of the child, and the name of the role player. Maybe repeat it a few times, like maybe speak it a few times that you know, because at times it happens is that you interchange the name of the mother and the child or the father and the child, and it gets a bit confusing. So maybe just repeat a few times that who are you going to talk to and who are you going to talk about them. But then again, write that, okay? Then make a detailed format for the history to be filled inside, which will include all the mnemonics so that you don't forget any part. So I'm going to tell you in the next like an hour when we are going to discuss that what are the parts of the history. So there are certain mnemonics that you can just write down first letters, and then what's going to happen is that when you just look at this and you're taking the history, you won't forget an important point, because you see there are a lot of things that have to be covered. Systemic review, like all of the systems, at times it happen if you have not properly prepared and not mentioned properly, you forget any system, or maybe if you forget the birth history, immunization, developmental, any of the history which was important. So I'm going to tell you the mnemonics and you can write them outside, and then when you take the sheet inside, then maybe just ask those and maybe you can take each point that you have taken, this history, this history, this history. Okay. Then make a list of differential diagnosis, DDs, differential diagnosis based on the opening statement. So I told you that in the opening statement, they're going to tell you a presenting complaint. Okay. It could be that the child is having headache. It could be the child is losing weight. It could be that the child is having a severe asthma, episode of asthma. He's having fits, any whatever the problem is. On the basis of that problem, have 2 or 3 DDs in your mind. Like if I tell you that you like today we are gonna do the history of headache. So when you see that you're given in the history outside that you're going to take history of a child who is having his headache, complaint of headache, write 2 to 3 differential diagnosis what could be of headache, okay, that you have to rule out in the history. Okay, then make a column on one side to write problems to be addressed in the management, which will include the organic and the psychological. Just a second. Okay. Yeah. So this is what I really recommend is that maybe on one side of the paper, maybe write, make a column or draw a line and just write the problems. Okay. So how this has helped me is that when you're telling the management, at times you do not really remember that what are the problems that you have to address to. So if you get time in between, just write 1, 2 words like if a child is of cerebral palsy and he has now presented maybe with some fits. So you have to give the management of the fits and everything. But for the CP child, maybe there are some other problems that the parents are having. They're having some tiring issues, any of the issues that they're having. So just write them down as well. So that when you're telling the investigations or the management, you are able to cater all of this. I emphasize on that in the RCPCH exams, focusing on the family, social problems, psychological problems, it is as important as the real problem is. If you're not going to address that, that's going to really, yeah, I'm so sorry. That's going to really hamper your marks, everything. Okay. Okay. So tips for communication while taking history. Sit straight with confidence. Just give me a minute. I'm just going to settle my child. Just a second. Really sorry. Thank you for understanding. Okay. So I was saying that tips for communication while taking the history. Sit straight with confidence. Avoid using a lot of hand movements, as I already told. Yeah. Maintain eye contact throughout. You can write in between, but avoid spending a lot of time on writing or looking on the paper. Be empathetic. We cannot emphasize enough that you have to be empathetic during the history station, during the communication station, any of the station in the clinical. Yeah. So pay attention to what the role player is telling. I'm so sorry, guys. Actually, I had some trouble. Hi, I'm really sorry, guys. I know it's first class and it's a really bad impression that I'm leaving, but for some reasons, my husband had to go out of country today, and my kids were creating some trouble. It's because it's their sleep time. So hopefully that won't happen again in the next classes. Okay, so coming back to the tips for the communication while taking history. As I told you, sit straight with confidence. Okay, we were on being empathetic. So you see that this stations, the history and all of these, parents are really concerned, like upset on the problem that has been happening. They're concerned that the child is having certain illness and any of those things. So you need to show that you understand their pain. You need to know, they need to know that you understand what they're saying. It's not just that you're definitely, it's all about acting. Like one of the things that you have to learn for the MRCPCH exam is definitely good acting as well, because um, you see, it's not just they need to know that you actually feel that. You have to tell it through your language, through your words, through your sentences. You need to, every one of you need to have some lines that you say in between, like, oh, I can understand that, or I know this must be really difficult for you. And you have to say them in a manner that really shows that you mean what you are saying, right? So this has to be done in a way. Keep your questions short and clear. Avoid asking multiple questions at a time. What happens at times with the candidates is that they simply just keep on throwing the questions. Like they would ask, okay, so did your child have fever? How long was it? Was like so the at times the candidate asks three questions at a time. So what happens is that, or they would ask like, does he have any pee problems or poo problems? So if the role player is going to say yes, it means that they have both the pee and the poo problems, right? So you need to be short, like, okay, does he have any tummy pain? So they, if the role player says yes, then you're going to go in the detail. Can you please tell me some details of that? And open-ended questions. Do not like give words in the mouth of the role player. For the initial ones, you always have to say just tell your concerns, right? And later on, when you're having a directed asking about directed systemic inquiry, then just ask clearly that can you describe his poo, can you describe his pee, or things like that, rather than just like asking that does he have diarrhea, does he have constipation. No, you don't have to ask like that. You have to ask, does he have any poo problem? If they say yes, he has any poo problem, then you need to say that can you please elaborate that further for me. Okay, so then they're gonna say that he has this, and then maybe you can ask that if whatever is required. Then don't dismiss the parental concerns. Again, that I'm telling you that if the parent is saying that I'm really upset, my child is not really getting well, or something like that, then be considerate. Tell that yes, we're going to help you with that. Yes, I understand, because at times they say that, oh, my husband died like at this age, or I'm a lone mother, I'm a single mother. Then you have to tell them that you understand that what they have been through. Okay. Okay, so introduction. Introduction is a simple thing. You greet the parents or the child. Usually we have parents. At times adolescents can come. Like I have been through the exam circuit twice. One for the mock exam, because in Pakistan they conducted a mock exam. So in that exam, I took like we took a history from a boy who was presented with acute exacerbation of asthma. So it was a history from the adolescent, but mostly it's a parent, like the father or the mother. Mostly at times it could be a foster care parent, or maybe an aunt or someone, but or a grandmother at times, but usually it's a parent. Okay, so just greet yourself. The way you will do it is that good morning or good evening. Good morning, Mrs. Sarah. I'm Dr. Iqra, one of the doctors here. I believe I'm talking to Adam's mom. So you have to greet, and then you have to confirm the patient identification. Like take their name, greet them, tell them that, like confirm that is he or she mother or father of like this child. Okay, so confirm the identification. Obviously introduce yourself, like tell that you are a registrar or whatever you want to say. I always keep it like that I'm one of the doctors here. I feel that's a safe thing to say. Clarify the role. I'm here today to talk to you about your concerns regarding Adam. So you have to tell it that why are you here today, and then take permission to make notes. So you need to say that I'll be taking, while talking to you, I'll be taking a few notes. I hope that's okay with you. So if I say it all together, it would be like, Hi, Mrs. Sarah. Good morning. I'm Dr. Iqra, one of the doctors here. I believe I'm talking to Adam's mom. Okay, thank you so much, mom, for coming here. Today I'll be discussing your concerns regarding Adam, and I'll be taking a few notes if that's okay with you. So if she's gonna say okay. So this is how you'll do the initial part. Again, just maybe some of you are noticing that my journal pace is fast and I talk loud. But when I'm talking in a sentence, like when I'm greeting a role play or something like that, your voice or something has to be toned down and be softer and be kinder. Okay, so now we come to what are the types of the histories that can come. So it could be a new disease presenting with complaints over a period of time. So, like, patient is having headache for some time, he's having tummy ache for some time, he's having like body swelling for some time. So, it could be a new problem with the complaint which has been happening over a period of time. Okay, so it could be like that, in which the case would be open. You will ask all the systemic history, you will ask all of the possible differential diagnosis, and then you're gonna give a list of differential diagnosis. So one of the type of the disease of the histories is that. Second is chronic disease with an active issue. It could be uh, in- previously what I feel is that the second category used to come a lot. This could be like a case of asthma who has presented with the acute exacerbation, a case of diabetes mellitus now coming with the hypoglycemia or the hyperglycemia, or a case of epilepsy, or any of the like the prolonged chronic cystic fibrosis used to come very commonly. So I feel that previously these kind of histories used to come more often. Recently, there has been a shift, and we now see a lot of first category histories in which there's a new disease. There's a complaint, like it could be body swellings, it could be what I got in my history was they would like the lumps on the bodies, which was lymphoma, right? So now this kind of case is coming. And the third is like a which is a new problem or an old problem, but it's an acute event history, which means that the child has now presented with an episodes of fits, or the child has presented with acute exacerbation of asthma, a child has presented with maybe anaphylaxis, or something which is acute episode. Okay, so what is different in all of these histories? In the first history, like if there's a new disease presenting with complaints over a period of time, you're going to get into the detail of the HOPI, like the history of presenting illness in detail, ask about all the possible DDs, look for the detailed systemic review, and then give your differentials at the end. In the cases of chronic diseases, you need to know what the acute problem is, like why is child losing weight or what's happening right now. Then you have to take a detailed history of the chronic disease that the child is already having. Like if the child is having cystic fibrosis or diabetes, you need to know that when was it diagnosed, how was it diagnosed, how has the course been, what teams is the child on, what treatment has he been taking, what complications of the treatment or the drugs that the child is having, things like that. Okay. And when there's a history of an acute event, so what's going to happen is that for the acute event, you have to know that what happened before the event, like before the event started. Like if a child had an episode of fits and now presented in emergency, you need to know what happened before that event. What was the child doing? What was the trigger? Things like that. Then what happened during the event, like what type of fit it was, like all of the details we are going to do later on. But what happened during the event and what happened after the event, like what did they do, how was he taken to the hospital, what was done there, things like that. Okay, so this is a basic difference in all of these scenarios. Okay. Okay, so presenting complaint. So presenting complaint could be one, it could be multiple. The thing is that you have to make a list of the current issues and note down in a chronological order, which means that you have to write down the presenting complaints in a way that the first complaint, the oldest complaint would come first. Like if the child has presented with weight loss for 3 months, decreased appetites for 3 months, and abdominal pain for 1 month. Okay. So you're gonna tell first that child is having decreased appetite and abdominal pain for last 3 months, and now present abdominal pain for 1 month. Okay. So I hope this is clear to you that it's like the oldest problem has to be told first and then to the recent one. Start with an open-ended question. May I ask you what are your concerns regarding Sarah? So let them speak. Allow the time for the child or parent to speak. So once you have asked first open question, give them maybe a minute, like a half to 1 minute, and let them tell all they want to tell. Like they would tell, yeah, he used to have this and blah blah, whatever they're saying. Okay, just listen to that without interrupting. Do not try to interrupt uh, the role player again and again. Then, after you have asked about the presenting complaint in detail, like maybe just ask that any other complaint, just be sure that whatever, because what happens is that once you are going downwards and ask about other things, maybe they say that he's having a problem as well. So, first be clear that what are the, is it only one concern? Is it any other one? Okay, okay. Then the chief complains for the known problem with an acute illness. Okay. So at times in cases, this is like our setting category of if the child is having a chronic disease and now presenting with some acute issues. So what happens is that at times when you're having this kind of history, the child could have, the parent would at times want to tell you something from the beginning and they would want to start from the very beginning and now come to the current problem, or they might start from this and then go to the previous. It can happen. Okay. So do not disrupt them. Okay, for the first few, like for sometimes sometime, let them tell whatever they want to tell. So whatever the pattern the history narrator feels convenient, go with the flow. If they start with the very initial problems, note that down and then proceed to the current problem. And if you like if they tell you the current problem first and then like go, try to move to the backward, that would be good as well. Okay, now so we come to the history of presenting illness. So this is our first mnemonic, OD Spara, or like ODS Para. At times people write it as OD Paras as well, but I like it's OD Spara and IMC. So this usually covers any of the presenting complaint. So history of presenting illness is basically the detail of the problems that the child is having. Whatever the problem the child, the parent has told you, you have to take a detailed history of that. Okay. So it would start with OD Spara. O is for onset. So you need to know, is the onset sudden, slow, like gradual or sudden? Okay. Duration. For how long has it been? They might have told you already, but you need to be clear for the how long it has been. S is for severity. Severity means that how bad is the thing that has been happening, right? It could be like something of minor intensity or something of bigger intensity. If specifically it is pain, then you have to ask to grade on the scale of from 1 to 10, 10 being the highest. If it's a complaint, then you have to ask its character and details. Okay. So severity means how, like if we are considering, okay, I'm telling like if we are taking the history of headache, then you have to ask about how bad is that, and then its characters, its details, like whatever you can think about that presenting complaint, like at what time it happens, is it like bad, any of the things, and what, like in what position it happens, is it like of constricting type, any of the things. Okay, so if the child is having weight loss, you need to ask its details. How severe is it? How do you know that it is, like have you measured, have you noticed, have his clothes grown, like he outgrown his clothes or something like that. Okay. Then progression. P is for progression, which means that how has it been? How has the course been? Like if the problem has started 6 months, since then till now, how has it been? Okay. Is has it increasing? Is it increasing? Is it decreasing? Is it static? How is it? Okay. Aggravating factors, then for anything that makes it bad, like for a headache, if it like anything is making things worse, relieving factors, taking any medication helps. Then associated features are that you see if your child is having any problem with maybe GIT. Okay, you have to rule out all the associated complaints of the GIT. Like if the child is having abdominal pain, then you need to ask about the diarrhea, about the constipation, vomiting, nausea, maybe jaundice, maybe urinary complaints. Okay, so associated features, right? So whatever the system is involved, like if it's headache, then you have to ask the detailed history of the neurology, nervous system. Okay, so rule out all the DDs. So exhaust the relevant system, rule out all the DDs at this point. Okay. So this means that whatever system of the complaint is, you have to ask all the relevant symptoms, and whatever diagnosis of DDs that you thought of, then you have to have that ask that in detail to rule out any of the possible causes, right? Then the IMC that we wrote on is investigation, medication, management, or current status. Investigation, like whatever the problem is, what have you, like, have you been investigated for that? Have you done undergone certain test or any of the things? Have you taken help of the GP, any of the seniors, any of the consultants or the specialists? Then medications of management. What have you done for it till now? Any medications, like if the child is having fits, then are you on any medicines? Are you taking it regularly? It's all of its details. And then the current status, like how is it now? Is it worsened, bad? Or like if the child is having recurrent episode of fits, how is it now? Okay. So this is the this IMC. So again, I would write. So what, as I told you in the previous one, that what do you have to write on the paper? So I would suggest you to write this ODs para and IMC about for the HOPI. That is going to tell you about how are you going to assess your problem. Okay. Okay. So important questions in the known illness. Again, I told you that I'm going to tell you side by side that when we have a chronic disease, a known illness, and now it's presenting with the acute thing, then certain questions that are important to ask here is when, how, and where it was diagnosed, what has been the course of the illness, all the complications and association of the disease, medications as well as the side effects of the medication, MDT team following the child, including the emergency plan, support in the form of educational, social, or the financial. Okay. So all the details of that disease would come at point if it is a chronic case. Then we move to the systemic review. For the systemic review, the mnemonic that we have is CHARMED, CHARMED, CHARMED. Uh, Okay, so there's a different point of view of people. Some say that you do not have to ask all the systems. Some are like that you have to ask. So what I believe is that if you're having a new case that I'm telling you that's been coming recently in the exams, then you definitely have to ask all the systems because you do not really know there's a disease. Okay, then you have to go for a detailed systemic like investigation. Ask maybe 2 questions per system, whatever are related. Okay, even if you feel that they're not very related, always a good idea to ask them because it's an open case. You are making a diagnosis. You need to know any of the problems that the child is having. Okay, in the cases when there's a chronic disease, in that what happen is that you're going to take the systemic review in that would come as a complication. Like if you're taking a history of a cystic fibrosis patient, obviously there are going to be some CNS complications of that, there could be some heart complications of that, there could be some respiratory complications of that, GI complications, any of the complications. So systemic review would come as a complication of the disease or the medication that has been taken. For the acute event history, usually if there's an acute event, then you do not have to focus a lot on the systemic review. Like if you have an acute history of anaphylaxis, you're not going to go for the systemic review on that. You're going to have the detailed history of that event, and then you're going to ask about the allergic stuff that goes on and how they're managing. If you're having an acute exacerbation of asthma, then you're going to have a detailed history of what happened before, during, or after, and then you're going to ask details of asthma, how is it being managed, all of those things. If it's not managed well, then what happened. Okay, so charmed, whenever you're asking a number of questions, because when you start taking the systemic review, there are a lot of questions that you're going to ask. So it's always a good idea to tell them that I will be asking you a set of questions to make sure that Sarah, like just like a name, does not have any of those issues. Okay. So just tell them that you're going to talk about many of other things rather because they might get upset that why are you asking all of this? Just be clear. So C in Charmed is for CNS. You can ask for headache, seizures, drowsiness, weakness, loss of consciousness, behavioral changes. Okay. Again, I'm telling you that you have to ask them in a very polite manner. Okay. Like you can ask, does Sarah has any headache? Does he has ever had any seizures? Do you think that she can walk, talk normally? Okay. Have you noticed any recent behavioral changes? Okay, so like kind questions. For the heart, H is for heart, which means like your CVS. You can ask palpitations. So you're not gonna ask that like does he or she has palpitations. You would ask that does Sarah or whoever is it says that does she complains of racing of heartbeat, racing of heart. Okay, or have you ever felt that his heartbeats gets really high or heartbeats very fast? Okay, so you see, most of you, I know that you might have gone through other exams or you have been in the pediatric training. You have to use simple words. Do not use any jargons. I'll share a file of jargons in your group as well, so that you can know that, because you do not have to use the words like abdomen or like nervous system or any of those things. You have to use simple, like you would say tummy. You wouldn't say that is the child, how is the stool, because they might not know what is stool. You would ask, how is it, how is poo, how is his pee. Okay, so simple words that you have to do. We're going to learn them when we are going to do practice as well. Okay, but I'm going to share the jargon file as well. So for palpitation, you would say that has he ever noticed the racing of heart, any swellings in the legs? Orthopnea, obviously you would not ask that does the child have orthopnea. You would ask like, does he sleep, when how many pillows does he take to he uses at night, or does he get like shortness of breath when he lies down straight? Then A is for abdomen. And abdomen, you know that there's GIT and hepatology both. So you would ask about the anorexia, vomiting, abdominal pain, abdominal distension, constipation, diarrhea, jaundice. Again, I'm telling you, these are all the possible questions that could be asked. I'm not telling you to ask each and every one of that. Just ask what you feel is relevant, okay, and what needs. So just one or two questions, okay. So if there is something about like something some about renal, okay, in which in the renal, then obviously you need to ask about the CNS, headache, seizures, okay. Then obviously have to ask about the heart as well. So all of the things are interrelated. Maybe just not like exhaust yourself in asking a lot of questions. So in the chart we have done C for CNS, H for heart, A for abdomen, R is for renal and respiratory. In the renal, you can ask about the dysuria, like pain during passing urine, or P. Hematuria, blood, like any change in the color of pee, flank pain, polyuria or the oliguria, and the blood pressure. In the respiratory, you would ask about the cough, breathlessness, noisy breathing. MSK, M is for musculoskeletal, in which you would ask joint pains, body aches. Then E is for ear, eye, endo. You can ask about any vision issues, any hearing issues, any swelling in the neck, heat or cold intolerance. And D is for derma, which would include any rash, skin marks, hyperpigmented marks, any lesions on the in or like on the skin or the body, as any of things. Okay. So again, charmed. C is for CNS, H is for heart, abdomen, renal, respiratory, MSK, ear, eye, endo, and derma. Okay. So mnemonic. Okay, next we come. Okay, so till now we have done this one mnemonic here, Odis para IMC. Then we have charm. Then we have for the rest of the history, we have a mnemonic which is PDF binds. Okay. So in this, we could say that this past, any significant medical or surgical history, any previous admissions. So the past history, okay, again, it depends on what kind of history you're taking. As I already told you, if it's a known case, then the past history is really important, and that's gonna come before any of other things. Okay. If it's a journal new history, then the past history would have any significant medical or surgical history, previous admissions. Pubertal, if the child is adolescent, then you need to ask for the pubertal history, the last menstrual period, uh, about the sexuality, having a boyfriend or a girlfriend. Then need to ask about the development. For the development, you do not have to ask the development in detail in every case. It has to be case specific. Okay. So what I suggest is that if you're having a child who is having fits, any regression, CP child, any having any of the issues associated to the CNS, then you need to ask a detailed history of the development. Okay. Secondly, so the first case is then when you are having something related to brain issues, with brain behavior changes, and you or anything like you think that there's some Wilson neurometabolic or any of those things which is associated with the regression. So the first thing is that in those cases you have to take a detailed developmental history. Second type of cases are when the child is below 2 to 3 years of age. He's really small. Okay. In that you have to take a detailed developmental history as well. In all the rest of the cases, like if there's a child of 7 years who is presenting maybe with the complaints of body swelling and is a, look like a case of nephrotic syndrome, and that you do not have to ask the each, because you see in the development you have fine motor, gross motor, speech, language, and all of those things. You do not have to ask those in details. Okay. Then, okay, I'm gonna comment on the question just a second, Dr. Ibrahim. For in those cases in which you think that the development is not very important, you just have to ask that, do you think that while growing up, maybe like we're taking name Sarah. So the Sarah was normal in her walking, talking, and interacting with the peers, or do you think that his development is normal like all the other kids of her age? Okay, so simple one sentence. Or do you have any concerns regarding the development, any of those things, right? Just a line to see that if she's doing fine and doing normally like the other kids of her age would do, that would enough. Okay, so I've told you three different scenarios of the development. So someone's asking about the why boyfriend or girlfriend to ask. Okay, so in the cases of the adolescents, a lot of issues come due to these kind of issues. Okay, um, like histories can tell you, like one, if I give you example, one of the histories in the recalls, there was a girl who was having a headache, and I think the diagnosis was the benign intracranial hypertension. Okay, and in that you had to ask that, is she sexually active or not? Okay, why? Because that's going to impact her overall. Is she, like, if she's sexually active, she's taking any oral contraceptive pills, that would be associated with their headache. Okay, so it's not important in everything. Again, I'm telling you, pivotal, and this one is important in the cases of the adolescent girls and the boys, right? Because that is going to impact on their overall health, on their overall activity, on their overall management. Okay, not obviously you're not going to ask about a boyfriend girlfriend in a 6 years old boy or girl. Then drugs means any illegal drugs. Okay, that, so again, these questions are those that you would not ask very, like, straightforwardly. You need to be very like, be very careful about that. I'm really sorry to ask you, I know, but it's just a routine question, and it's okay if you don't want to ask her. Do you think that your child takes any drugs or any of the other substances, any of the other things that he use? Okay, so see, like my voice and tone has gone a bit more down, a bit more slower. Okay, and then you have to use these words whenever you're asking about sexuality or things like that. I'm really sorry to ask, but it's just a routine question, because you have to ask, like, if there's a case of asthma, you need to know if that child is smoking or not. Okay, so you have to ask. Sorry, someone with the name of iPhone has said repeat. What do you want me to repeat? Please specify. Okay, so you need to ask it in a very, very friendly tone and with some of the apology, and maybe just say that, okay, if it's okay if you don't want to answer, that's your choice. Okay, so be very, very reluctant and be very careful and sensitive about these things. Then P was like for past and pivotal. D is for development and drugs. F is for family. So detailed history of the family and history of consanguinity, relationship between the mother and the father, number of kids, uh, and any of the similar illness or the complaints in the family. Okay, the sentence for these sensitive questions, yes, you can say it in a way that, I'm really sorry to ask you a few questions. These are just routine questions. Do you have a boyfriend or a girlfriend, or does your child is sexually active, or do you think that your child takes any of the drugs or any other substances? Okay, so this is how you can ask. Obviously, you can modify it on your own. I'm just giving you an example. I don't want you to repeat my things. I want you to create your own lines for the history. Then B is for the birth, which would be prenatal, natal, and postnatal. Again, in the cases where you have a CP child, a developmentally delayed regression, Rett syndrome, something like that, you have to take the birth history in detail. Otherwise, just have when you were pregnant with like Sarah or anyone, like, did you have any issues? How was the pregnancy? How was the birth? Were there any other issues after the birth? Just like that. Okay. Do not have to go in. Yes, you can use the word sexually active if you want to ask. Yes. Or you can ask if you don't feel like, you say that, does your child have a partner? Okay, but sexually active, yes, you can use. But I'm again telling you that you have to ask it very sensitively. You do not ask that question right in the face. Okay. Then eyes for immunization. Then you'd ask that your child got all the jabs or the shots? Nutrition, 24 hours calories if relevant, depending if there's a child of celiac disease, cystic fibrosis, if the child has presenting with a weight loss or something like that, then you have to ask for that. Then you can ask that, are you in a regular follow-up with the GP? Is he growing normally according to his charts? Or like, do you have his growth charts with you? And then any drug or food, then okay, so we were with B is for birth, I is for immunization, N is for nutrition, D is again for drug or food allergy. Okay, so allergy, you have to ask for the allergy. Is your child allergic to any of the medications or any of the foods? It's good to ask that in every case, but in the cases in which there's a history of anaphylaxis or asthma or atopic asthma, like atopy histories, in that one, there's a really important to take detailed allergy history of drug or food. Okay. Then SSS. First S is for the social, which is very important. Again, see, I've written it here again. You have to ask about that how the family members are dealing with it, how, like, what is the relationship of the child with his sibling, what is the family income. You have to ask about it. Again, these are the questions which are a bit sensitive. You cannot ask that, what is your family income? So you would say that, okay, so who earns at home? Or like, what do you and your husband do for a living? Do you think that your income is satisfactory for your living? Okay. Then home details, if like specifically in the case of allergy, you have to ask like, can you tell me a little bit about your home? Like in what areas do they live? Because you see in the certain areas, when in the cases when you have some regression and you are suspecting lead poisoning, you may need to know that if they're living in a very old house or something like that. Okay. So you in this the social history that you have to ask their social life, how is it? So how is this condition affecting you and your family? Okay, are they having like, it could be like, the mother could be a single mother, divorced mother. She could be, the child could be like born out of marriage. She's the only caretaker. Like if both of them are at at work, like if you say that they say that both of us are earning, or like both of us do jobs, then you have to ask that who takes care of the kids at home. Okay, things like that. So you have to ask about the income, about the duty. Then school, if the child is of school going age, then you need to ask that, uh, just a second. Okay. So school, if the child is of school going age, like if the 7th, 6th, then how is school going? How is there any, are there any missing days due to this disease? Or is the child going to special, like in the cases of adolescent, how is the relation with the teachers, with the peers? Is the child facing any bullying at school, any of the issues? Because if there are any issues with that, then you need to cater that. Then you need to take care of that in your management plan as well. Okay. Then special help. Are they getting any financial aid, any social? Are they like involved? Are they linked to any groups that of the similar illness? Like specifically in the cases of chronic diseases, are they member of any of the support groups? Are they getting any aids? Because you know that there are some disability living allowances. There are some helps that are being given from the UK government to the people who need it. Okay, so any of the help that they're needing, sorry, they're needing or they're getting. Okay, okay. Then there's a thing which is called heads assessment. Okay, so this specifically is the thing that you have to look for in the cases of any adolescent who feels like that they're going through a difficult time. Okay, like if I give you example, a child of asthma who has come with exacerbation, and now you know that he is on, like his exacerbation got worsened because he was not taking his medicines properly. Okay. and he was not, because he's like growing up, he is having certain issues and he's not taking his medications. So in the cases of the, or like there's a child of diabetes mellitus, and his blood sugars are being continuously high, he's not properly being. For teenagers, yes, this is for teenagers. Dr. Ibrahim, someone has asked that is it for teenagers? Yes, it is for the teenagers. Yes. So someone with a diabetes mellitus recently whose blood sugar levels have not been in control, then those ones that you have to take an assessment. This is called heads assessment, in which you need. I think we have covered a lot of things in our previous mnemonic as well. But then again, because this term is being used, so you need to know H is for home, like how his relation at home, any conflicts at home, like is it a single parent, single father, mother, or anything like that. Then education, employment, eating. Education means again the school things that we have discussed, employment, like if they are into that, or the eating issues, because at times females are having some eating issues as well along with this stress. Activities, how active are they normally at home, outside, how are their friends. And drugs, again, I told you that uh, drugs, like are they taking any illegal substances or not. Okay, so if you're taking history from a teenager, then you need to ask from them, okay, but in a very, very careful and a sensitive manner. Then again, S is for sexuality, S is for suicidal or the depression. Maybe you don't need to ask that very clearly, but you need to keep in mind their mind that if they are saying something like that, you need to consider that, okay? And then S is for safety, like how safe they are in their usual living. Are they taking care of all the precautions and all of those things? So this is a proper assessment plan, okay? But you need to ask a few questions in the history. But I think we've already covered that in our history format. So most of that is covered. Then impact of the illness and support provided. Okay. So how is this disease impacting? So on patient, physically, psychologically, socially. I've discussed, I think, previously as well that how this is impacting, but why have I kept it? Because it's really important that how this is happening. Is the child like doing normal activities? Impact on the like again, I'm telling it's impact on the patient and the family. So then the patient, like physically, school absences, his journal, like if there's a child of GIA, how if and he's having multiple joint swellings and joint restrictions, obviously his physical activity is being really, really affected. He's not able to move around, he's not able to do any of his things on his own. How is this affecting the child psychologically and socially? Like, is he being able to come in, like being friends with others or not? Then on the family, how is it impacting them financially, psychologically, socially? Because you see that if one of the child is like getting ill again and again, then you need to ask that like who takes care of the rest of the kids, and how the all the rest of the kids are being managed. Okay, so impact on like how other siblings are being affected. So usually I tell you that you do not have to ask these things specifically differently. Okay, the role players are told, they are guided and trained in such a way that you would ask that how is these, like if you should say that, okay, so I know that the Sarah's condition must be really upsetting for you and your family. So how are you managing it, and how is it affecting you? So the mother is gonna tell you all. So she's gonna say that, yeah, it's really difficult for me, I'm the only earner and I have to go to my job and I don't know that what to do. So she's gonna tell all of those things on her own. Okay, usually this happens. It's not like that you have to ask them that is how is it affecting you financially, or how is it journal statement. Okay, but then again, you have to keep all of these things in your mind. And then after each problem, ask about how they are coping. Okay, so maybe not after each problem, but generally once or twice, just be kind to them and see that how they are managing. Like if the child is being getting admitted or being affected, like uh, getting ill again and again, so how they are managing it, right? If they are not sound, financially not sound, then how are they managing? Okay. Okay, so closing statement would be that, like, ask if there are any other concerns you haven't addressed yet. I have taken the important. Okay, so you would say that it's always a good idea that whenever you're finishing this, ask them that, do you have any other concerns that you think I have not asked yet? Because at times, the history, the role player has something in your mind. you might missed it, because obviously there are so many things to ask. So before ending this, because you, at times it happens that when you ask this, they're gonna tell you something else. Okay, so there's always something that might have been left. So it's always a good idea to ask this at the end, that let me know that if there are any other concerns that I have not asked yet, or any of similar lines. Okay, and then just close it by saying that thank you so much for coming in and telling all of those things. I have taken the important notes, and I will get back to you after discussing with my team. Okay, so just a thank you note, thank you closing statement, and maybe usually it's good that you end in time, and even if you do not have completed it the way you wanted it, then then just maybe just close it in a good amicable way when they knock it and say that 30 minutes are over, and then this is your ending of the history. So till now, if any of you have any questions regarding the history, please feel free to ask for the right, so that I can clear and then move forward. Okay. Someone has asked in the chat that in this slide, coping or not coping, is there any government help direction? Okay, so I'm gonna provide you with certain resource in which you can know that what kind of different aids are available in the UK system. Like some of the commonly are the disability living allowance, DLA. Okay, then there is something that you would call like something associated with the epilepsy as well. Then if you are like really far away from the hospital, they might provide you some extra thing. They might provide you some extra care. Then if there's a patient of the cystic fibrosis, he's registered the cystic fibrosis team, he might be getting some help. So different kinds of help are being given by the government. Okay, so general thing would be that, are you receiving any financial aid or any other help from the government? That would be sufficient to know that are they having any extra aid from the external source. Okay, any other questions? Okay. Should I think that you guys have got all it, or should I think that, okay, someone has written, sometimes taking history from a team, it may be really difficult to get a history of drug if they refuse how to handle teenager. Okay. Okay, if you feel like at any point any of your question feels offensive to the role player, just apologize and move forward. Okay, I've just tell them that I'm so sorry that you felt that way. I'm really sorry that I asked this. Okay, we can move forward to the next point. Okay, do not be persistent and ask it that I have to get this history from you. Okay, again, in the history, it's not really of an issue. Usually, these kind of things happen in the communication station in which any of your things is being misunderstood and the teenager or the role player gets aggressive or things like that. I haven't heard much in the history that a teenager would be like, it could happen that they do not want to answer. That, as I told you, that in one of my histories of an asthmatic patient of a teenager, he was like really, he was like, I don't know, something like that. So it was a bit of an effort. So in that, what would happen is that your initial and your ongoing communication with the role player, okay, encouraging him, you're like saying things in between that, oh, you're doing it really well, any of those sentences that is becoming the good, that is making a good rapport between you and the role player. Okay, so that's gonna matter how that, like, if you have a good rapport, if you feel like that the role player has become a good he has made a good interaction with you, he has developed a good relation with you, then when you're going to ask these kind of questions, he might not get offended. But if they do, then just apologize. I'm so sorry that you felt this way. I did not mean to offend, say it this way, or it's totally fine that if you don't want to ask, I just asked because it was a regular thing, or it was just a question, a regular question. So we can move forward to the next thing. So just move to the next thing. Okay. Okay, any of further questions? We have a lot of people here. Okay. Okay. So I hope there are no questions because things are clear and not because there's nothing in mind. Okay. So we'll move towards, I think, like I know that I'm taking a lot of time on this introductory lecture, but believe me, it's really, really important because if we have set our base right in this very session, then the next sessions, all of those things are gonna be really, really easy for us. Okay, so bear with me for like another 10 minutes for this one, and then we move towards the history taking. Okay. So after you're done with your 13 minutes, okay, then your next 9 minutes starts, in which, and people say that if you do not know about the topic, it could be the longest 9 minutes of your life. But I'm pretty sure that like we are gonna prepare you very well for the history station, and your 9 minutes are gonna go in a second and you won't feel that it's a very long time. But you have to give your summary of the case. Okay. So your summary should be like really good. Oh, you have taken history for 13 minutes, and in all of those things, what you need, what's important in summary is that it's not that you have to tell each and everything, but you have to tell the crux of the matter in good, crisp, well-formed sentences. Okay, so whatever the problem is, all the important, like all the positive findings that are associated with that problem, all the important negatives of that problem, okay, a little bit about all the histories, and then about the good, telling about the social and all of those problems. Okay, so you see that people say that how long it should be. Usually I personally suggest that history of the, like the history taking station, summary of history station, it should be around 2 minutes. Okay, because you see there's a, you have taken something for 13 minutes. You cannot like just tell it in like 30 or 40 seconds. You need to tell it in a good structured way, in a way that the examiner understands that you have ruled out the differential diagnosis, you have made something in your mind. It's not simply repeating all of the things that the role player has told you. That examiner has already listened to and registered. It's about how your perception is about that case, how you think that problems is associated with certain things and certain nothing. Because you see, in the history there are a lot of distractors. Okay, it's not going to be simple things. I was just taking a feedback from one of the candidates yesterday who gave an exam in the UK center, and she said that the history section at times feels like really clueless. You don't really understand that what history that they are giving. Okay, so like what she was telling me was that they have been like recently the histories are coming which are not very straightforward. There are two things that are going in one direction, and then there are two things that are going in another direction. Okay, so the examiner wants to assess that after you have taken 13 minutes to ask all of those things, have you made your mind clear that which things are important regarding patients and which are just a distractor. Like if I tell you, I remember when my history of lymphoma was in the exam, there was some the parent kept on telling that the child was a very good swimmer, things like that. To a point, like he repeated that line so many times that I actually thought that there's something wrong with the, like there's some association with the swimming. Maybe the child has got some disease which is related to swimming. But then I just like I felt that it's unnecessary. I skipped it, and I like did not. There was no mark cutting due to, it was not important. So they are gonna be distractors. Okay, you have to be focused on what history you have taken and what diagnosis you have made in your mind, right? So a good summary is really important. We are gonna work for that in our classes. Each time I'm gonna take history, I want you guys to obviously tell me the summary, and then I want all of you, all the participants, to write the summary for that case of your own and then send it to me. Okay, so we're gonna work on that when we start the classes. After that, after giving the summary, the examiner is going to ask you what do you think is wrong with the child, what is the diagnosis, and what is the differential diagnosis. Okay, then you're gonna tell about the differential and whatever you feel like are there. Okay. After that, so your next question is that how are you going to examine that child? Okay, because you see, there's not a real patient. You have to narrate all of these things. So next questions usually about the examination. For the examination, it's always a good idea to start with a journal examination about weight, height of the child. Okay, his journal built looking, then vitals of the child, then the detailed examination of the main system. Like if it's a case of neurology, then you have to tell that I'm gonna do a detailed motor system examination, cranial nerves examination, sensory examination, and then move towards the rest of the examination. Okay, so whatever the case is, like if it's something related to the abdomen, then you have to tell that I'll do the detailed abdominal examination and then look for this, and this, and then move. So you have to narrate how would you examine that child in a real scenario if you would be looking at that child. Okay. Then the investigations you have to tell about the specific investigations. If you think any of the specific investigations are required for the disease or the differentials that you are thinking about, and the supporting investigations, right? So it's not like that you have to start a list of investigations like I like to do the full blood count and the urea electrolytes and the FTs and RFTs and blah blah blah. Okay, not like that. You have to be directed and clear that if the child needs investigation, then I'm going to do that. If you feel like that no investigation is required, then just skip and just say that currently, like I would like to just review the previous charts and no investigation is required. Okay. So if the investigations are required, then the specific investigation, supportive investigations. If it's a chronic case, then you would say that I will review the previous investigations as well. Always remember to mention the involvement of senior and consultant when you're telling very hi-fi investigations. Okay, as I told you in the initial ones, you are see they've told you again in the description as well that they expect you to have a level of around like ST2 training. Okay, so you need to know that what are my limitations. Okay, I cannot, like being a trainee, you cannot go for the MRI or maybe CT on your own. You need to have an involvement of your consultant before going for an MRI. Okay, so it's always safe to just mention the name of like I'll involve a senior and a consultant and then tell the investigation so that you're in a safer zone. Okay, and then any of the investigations that you think are required. Then coming to the management plan. Initial few things in the management that you have to tell are that if a child is presented in a sick condition, if he is like really in a bad condition, then you and needs admission, then you have to tell that like I'll admit the child. Okay. If the child is having any of the infectious diseases that you think it needs to be notified, you need to mention that. You have to tell about the initial management steps, initial stabilization, like maybe if there's a child of GIA, you do not have to start telling about the hi-fi medication. You have to start with the basics, like with the antipyretics and analgesics. Okay, so these are the basic things that you would tell. Then about journal management points, like what journal healthcare would you like to do? Like if there's a history of headache, then avoidance of the triggers, journal counseling of the child, reassurance, if only because literally I'm telling you that yesterday the feedback that I was taking, the candidate told me that the history was literally of something like viral induced base. Okay, or I think some would like the viral infection of the chest. As simple as this, there was no other thing. Okay, no asthma, nothing like that, simple viral infection. In that, it is important to tell that you just need to reassure. Okay, you do not have to give like keep on telling like multiple investigations or the medications. You, if there's only reassurance is required, you need to tell that. Then always tell about the involvement of the multidisciplinary team. As I told you that they expect from you to like to tell them that what like how safe doctor you are. So you need to tell them that I would like to involve like neurologist if you think, a geneticist, if there's a CP child, maybe some therapist, nephron, any of your things, any of the thing that you can think, maybe a nutritionist, at times maybe a psychologist. So any of the things that you think teams are important and they're needed for the management, just mention that. Always address the social concerns. As I mentioned earlier, if the parents are having financial issues, offer them that. A social worker, if they're having some other kind of issues, then do consider them. If they're like the teenager is having some school issues, then tell that you're going to talk to the school have a liaison with the school authorities and like try to make things better. What helps can be offered, like the support groups that could be offered, any financial aids that could be offered, emergency action plans. In the cases if the child can go into some like acute issues like exacerbation of asthma, hypoglycemia, any of those things, then you have to tell that you're gonna give the child or the parent emergency action plans. Okay. Um, and then after all of this, then just a few tips that how you should you prepare for the history station. So I would suggest that since you have started, like obviously if you have joined the course, then you do have in your mind that you're gonna give exam in next 6 months, hopefully if you get the seat. So how would you like to prepare? Maybe start, if it's very initial, if you're saying it's a very, very initial time, just maybe do one history at a time. But like go for at least 2 histories per week. Always have a good practice partner. This clinical exam is all about practicing. You cannot expect to speak fluently, to ask the history fluently, to clear the thing, tell the things, unless you're practicing it with a partner. So have a good partner from the very beginning. Reading guidelines is a must. Guidelines are a strong yes or a strong base for your question answering. Okay. In the history, obviously, that's about practice, how to take the history, but how you answer the things are, they should be all be about the guidelines. The guidelines I'm talking about are the pediatric guidelines, bedside pediatric guidelines. The recent one till now that we have is 22 to 24. Let's see, maybe in the next few months we can have the new 25 to 27 guidelines so that we can have that. They have all the important topics. You have to go through them from the headache to the nephrotic syndrome to the JIA to the cystic fibrosis to hypoglycemia, asthma management, all of the things. I think it has all of the important ones. So do go through the guideline book. If you feel like that some topic, some history has come which in which the guidelines is not mentioned in that book, then just log in, just write on the Google of that disease and write the NHS guidelines and read any of the guidelines. But your answers should be according to the guidelines. Okay. Go through the available notes. There are a lot of, obviously we are going to give you the data as well. We are giving you the live classes, we are teaching you the live things. If you still, you can I think you personally, you should make your own notes depending upon how we go through the sessions. If you feel like there are multiple notes in the in the circuit, I think, which have been going around, you can always have a look on that. Always go through the recalls. History session do repeat in one way or the other. Maybe the topic is same, something they've asked a different type of question, but the topic remains same. So do go through the recalls. Okay, and keep practicing that. Yes, we will share the recalls. Someone has asked about the recalls list. Yes, we will definitely share the recalls list with you. So with this, we come to the end of presentation. Let me know if there are any further questions. Otherwise, let's just take a break of a few 3 to 4 minutes. Let me just get a glass of water, and then we'll be coming back. Also, who is going to practice with me for the next station? Okay, I can see that we have around 20 participants. Okay. Anyone? Because you see, this has to be an interactive class. Maybe obviously once we get into the groove of this and once we start doing this, it will, you guys are gonna be comfortable. But we need someone, because obviously it's not gonna make sense if I just give this clinical session to you as just a simple teaching lecture. So let me see the names of the candidates. Yes, we have this Dr. Raida in our session. I have some names. Dr. Raida, Dr. Rabia Salim, Dr. Siva, Dr. Amber, Dr. Anu, Dr. Anjali, Dr. Shahida, Dr. Khatija, Dr. Soon Shafi, Dr. Susie. I think maybe I can see Dr. Susie here. Dr. Venkat, Dr. Hina, Dr. Akshay, Dr. Ashok. So, Dr. Ashok is here as well. Welcome everyone to our lecture, our class, and maybe Dr. Anuradha. So please give me a name. Who, okay, just say anything. I really want you guys because I don't think if we don't have a candidate, it's gonna be really difficult for us to go through the session. Are you guys having any difficulty? Are you feeling having any fears or anything? You can talk to me about that, and maybe we can clear that. Or if you think there's another
Good evening,
way,
ma'am.
yes. Good evening.
I'm Dr. Dastagir, and I can go with the next topic now. I will
Okay,
try.
okay, that's great. Okay. Okay, so we're just taking a break for a few minutes, and with that, after that, I will be starting with the history, and we'll move for that. Okay, so I'm back. So, can you tell me that who offered?
Myself, Dr. Dastagir, ma'am.
Okay, okay. Thank you, Dr. Sagir. Are you preparing for the exam?
Yes, ma'am. Actually, my AKP finished on.
Sorry, your voice is a bit like it's not very clear. Can you speak again? I cannot hear you. Can you speak again, Dr. Dastagir? It's looks like that you're speaking from very far, far away.
Hello.
Yeah, now I can hear you.
Yeah, sorry, ma'am.
Yeah. Yes, can you hear me? Yes, we're listening.
Yeah, yes, ma'am. Yes, ma'am.
Okay,
Sorry,
so
my
you're
bad.
preparing for the exam?
Yes, ma'am. I started preparing recently, ma'am.
Okay, okay. And have you like booked your exam?
Uh, can you tell me again, ma'am?
Have you booked your exam or you're still like preparing?
No, no, ma'am. Just I started preparing. I'm from
Okay,
India,
okay,
so the next date will be in September or in November. So I will try, ma'am.
okay, okay, right. Okay, so thank you for like coming forward and volunteering for this. Okay, so are you comfortable with the screen on or do you want to do it the off screen?
Yeah, I'm comfortable, ma'am.
Okay, okay, so I'm sharing the, okay, this is your station. You have 4 minutes to prepare. Okay,
Okay,
I'm
ma'am.
starting the timer. After that, I will start. Okay,
Okay, ma'am.
take your time to prepare your notes.
Yeah, this is my first time, ma'am. Okay, I will try.
That's totally fine. That's totally fine. No one is going to judge you. Okay, we're just here for learning.
Thank you.
Yeah. You just, if you have volunteered, I think that's brave enough. And that's your first step towards excelling in your exam. So when you're gonna give your exam, you're gonna remember this time. So just take your time to like make a format or something, and then we'll start in 4 minutes. Okay.
Okay, ma'am.
Okay, you ready to start?
Yes, ma'am.
Okay, so you
Hello.
know that, yeah. So do you feel like, do you want to switch on your camera?
Mm. I will continue like this only.
Oh, okay, that's fine. That's fine. We'll do that. Okay.
Hello, good
Okay,
evening,
so you know that, yeah, it's a 13-minute station. I'm starting the timer and I'll
ma'am.
notify you at 9 minutes that 4 minutes are remaining. Okay?
Okay.
Okay, let's start.
Hello, good evening. Myself, Dr. Dastagir, one of the pediatrics doctors here in this hospital. I believe you are Mrs.
Good
Anna,
evening,
mother of
doctor.
30-year-old Adam. Is it correct?
Yeah, doctor, that's me. Yes, that's me.
Yeah, nice to meet you, Mrs. Anna. May I know
Oh,
what are your
thank you.
concerns regarding Adam?
Yeah, doctor, he's been having headache for the last 6 months, and I've noticed that
Okay.
it's becoming worse for the past few weeks, and it's really concerning me.
Okay. Can you explain about headache? Like when will it start? And what is where is the
Mm,
exact location?
okay, so I can't really tell that when does it start. At times it's in the early morning, at times it's in the evenings as well, but mostly it is in the early mornings, yes. And he said it's like it's all, in all his head. He cannot really tell that is it in a specific part.
Okay. Like can you scale the headache from 0 to 10?
Mm, I think maybe it's around 6. Yeah.
Okay. Like does he have any other issues except the headache?
I think headache is the main issue that's bothering me.
Does he have any vomitings, any fever?
Um, I think fever, no, he like the regular fever, the usual that can happen to anyone, not the something which is going on. And about the
Okay.
vomiting, no, I think maybe once in a while, but not something which is like a continuous feature.
Okay. Did he take any medications for his headache, or did you visited any GP for that?
We have been to GP quite a few times, and they just prescribe paracetamol, and he often takes that, and pain does get better with the paracetamol.
Okay. So when did his headache will better, and when did he feel his headache became worse? Can you explain?
It's been getting bad for the last few weeks, and these days
Okay.
he's been complaining a lot. Like when he wakes up, he's like he feels lethargic and he has headache. And due to that, if I tell you that he has not been like very good in the school as well, he's missing some classes because he doesn't feel active and doesn't feel like going to school.
Okay. Does he have any headache on bending, on coughing?
I don't think that's a feature of them that not yeah.
Does he feel any difficulty in his vision during the time of headache?
Vian, like what can you be specific? What kind of problem?
Like moving, like he's feeling moving of objects during the time of headache, or difficulty to seeing the light during the time of
Doesn't
headache.
mention that. He does mention that he feels weird when he has pain, but about this vision thing, I don't think he's mentioned that.
Uh, how can he feel his headache? Like it's like a band type headache, whole the head, or it is pulsatile on one side. Did he mention
No,
like that?
nothing. Times he says it's in the whole head, times it's on one
Okay.
side.
Mrs. Anna, can you hear me?
Yes, now I can hear you.
Uh, so now I'm going to ask a few set of questions. make sure that Adam doesn't have any of these issues.
Okay.
Like, does he have any episodes of fits or any dizziness, any weakness, any loss of
Mm,
consciousness?
oh, I don't think so, but I do feel that he feels lethargic and at times dizzy as well when he gets headache, but no fits.
Okay. Does he have any chest pain, cough, difficulty in breathing?
No.
Okay. Does he feel any racing of his heartbeat, any swelling in his legs?
Yeah, when he has headache, he does feel that his heart beats faster. He mentions that.
Does he have any tummy pain, any problem in his pee and poo?
Not really. Nothing significant.
Okay. Does he have any joint pain, any rash all over the body, like any lumps and bumps?
No, nothing that I can think of.
Okay, okay. Did he feel any similar episodes in the past, like
He
this kind of
is,
headache
yeah, I told you that he's been having it for the 6 months and it's been off and on, but now it's
previous that?
become more frequent.
Okay. Previously, before 6 months, he didn't have any episodes like this, right?
No, there was no headaches before that.
Yeah, that's great. That's great. Is he coping with his peers? Like, is he developing well?
Yeah, he's developing okay. He goes to school, but issue is that he's one of the short boys in his school. So
Okay,
he's really upset about that. His height is
I can
kind of like small compared to me and my husband and his other siblings. And this really
yeah,
affects him.
yeah, I can understand your concern. Like, any of your family members have a headache, like these kind of episodes?
Um, I have this like episodes of migraine and I do
Okay.
take medicine for that. Yes.
Uh, how many persons will live in your family?
Yeah, it's me, my husband, and I have two other kids, and both of
Okay.
them are younger. Adam is my first son.
Okay. Are you working or?
Oh no, I'm a stay-at-home mom.
Okay. How is Adam's eating habits?
Oh, he's a very picky eater, and he doesn't like really like a lot of things. So I just need to be very careful what to give him. So yeah, he doesn't eat much unless it's his favorite food.
Okay. Um, how was your pregnancy? Like, is it completely normal or any abnormality in your pregnancy
Well,
during the time of the delivery? Or,
it's been a long time, but I don't remember anything significant. It was pretty okay. I
oh,
don't remember anything bad.
okay, no problem, no problem, no problem. Did he take all his jobs?
Yes, yes.
Okay. So except that paracetamol, he doesn't take any medications for his headache, right?
Yes, he's only taking paracetamol.
Okay. Does he have? Are you taking? Sorry.
Sorry, can you repeat?
Uh, does he go to his school regularly?
Yeah, doctor, I told you that recently he's been missing a lot of his classes and
Okay.
he spends a lot of time at home. I don't know, is there something, if probably I feel that there's something going wrong at school as well because it's not really going well with his peers. He likes to stay at home. So he just spends most of the nights at home watching TV and screen and playing games. And then he like sleeps till late in the morning and complains of headache and like misses 4 minutes left. And he missed
Okay.
schools as well. 4 minutes
Okay.
left.
Okay. I can see he's a teen. So I'm going to ask a few personal questions. If you are okay, you can share the details, or else you can skip the questions. Is it okay?
Yeah, that's fine, doctor. Yes, you can ask.
Does he ever try smoking or any drugs, any alcohol consumption like that?
Doctor, I don't think so. I mean, I maybe outside, but I told you that recently he's just been staying at home and he doesn't go out much with friends and all. So I don't think so.
Uh, does he have any girlfriend like that? Do you know about it?
No, none that I know of.
Okay. I think I have completed my history. If you want to share anything, you can ask about Adam's health condition.
Yeah. So, doctor, I want to tell you that his headache, all of this is really affecting me and my family. You know, that recently, as I told you, that he stays at home, he's not having a good relation with his siblings as well. And I just have to be like taking, he's a big boy. I can't say much to him as well, but I'm really upset that why is this happening to him and why
Yeah,
is he behaving in this way? And this is really affecting all of us. So yeah,
I'm really sorry to hear that. I can understand your concern. I have taken the important notes. I will discuss with my consultant. I will let you know what we can do for Adam. Is it okay for you?
yeah, doctor, that's fine. Thank you. Okay, so you still
Thank
have 2 minutes. Maybe just think of anything that you want to ask. Just go through that and let me know that if you want to ask any other thing.
you. I can ask about his puberty. Did he hit his puberty? Like, does he have any axillary hair, pubic hair?
He has started developing. Yes.
He doesn't have any visual issues, right? Does he wear any glasses?
No, he does not wear any glasses. His eyesight is
That's
fine.
great. That's great. You mentioned his height, he's short, right? But how about his weight?
His weight is okay for his age.
Okay, that's great. Yeah, I think I have completed. No,
Okay, just give me a second. I just okay. Okay. So at this point, I'm gonna ask from a summary, but since this is a teaching session, any one of the candidates think that some other questions have to be asked. Anyone wants to ask anything? If you have been listening to history, I hope you are. Do you think that there's anything that has to be asked? Just ask me and I'll answer that.
Any weight loss or night sweats?
No, there's no weight loss, no night sweats. Okay, since someone has written in the, okay, I'm going to read the comment section. Someone has written since when he was short compared to the others. He has been short since the beginning, like since the smaller age. Vomiting, no, there's no vomiting. I think doctor, okay, the time's up. Okay, so Dr. Dastagir, please summarize your nine
no.
minute starts. Please summarize your case.
Today I got the opportunity to speak with Mrs. Anna. Like she came to hospital with Adam with chief complaints of headache for the past 6 months. The headache is mostly all over the head. On severity scale, it is a 6 by 10. The frequency has increased recently, and he doesn't have any red flags in the form of early morning vomitings, any change in behavior. But the mother feels that he doesn't have a proper relationship with his siblings in the family. There is a family history of migraine for the mother.
Okay, yes.
He's a picky eater. this condition is improving. This condition is impacting both child and mother. Like child is missing his schools and mother is very worried about this condition.
Okay. Anything else that you want to tell?
Mm, I don't know, ma'am.
Oh,
I
that's fine.
think
Okay, so what do you think? Whatever history you have taken, what do you think? What differential diagnosis would you like to give?
yeah, most probably it's a case of migraine.
Okay. Okay. Any other differential?
Like it might be a medication overuse headache,
Sorry?
medication overuse headache. But there is
Okay. Analgesia, headache, medicine overuse. Okay. Okay. Any other
he
type of
doesn't
headaches
have
that you can think of?
cluster headache.
Mm-hmm. Okay. Okay. There's another type of headache involved. Okay. Okay, we're gonna go do in the okay. We're just like doing some brainstorming. That's fine. Okay, so how would you like to examine?
So first, I will do the complete head-to-toe examination. I will take the vitals like BP, pulse, and saturation of the child, and
Okay.
I will examine the complete neurological examination of the child and cranial nerve examination.
Okay. Okay. So how would you like to investigate?
So at present, he doesn't have any red flag signs. So I think there is no need of any investigations at that time. I think so.
Okay, what are the red flags associated with headache?
Like sudden recent onset of any sudden headache. So and there is early morning vomitings and disturbing the child's sleep. Any postural headache, like headache increasing on bending forward and coughing or any sleeping.
Okay.
Associated with any growth abnormalities like delayed growth, short stature.
So do you think that this child is associated with that? Like this child is having short stature?
But it might be a familial short stature.
Okay, so did you ask about the parental family, the parental structures?
No, no.
Okay.
I, I
Okay.
think his mother mentioned that both his parents are normal height. I
Yeah,
forgot
she
that
does.
point.
Yeah, she did mention that. Yeah. Okay. Okay. So moving forward. So how would you like to manage this child?
So first I
Okay, first tell me
will
that what are the problems of this child, according to you?
it's more like positive findings now.
Yeah, the problems that you would like to manage. So one is the headache that would you like to address in the management. What else?
Like they have issue with the height of the child,
Okay, the height of the child. Okay. Okay. So,
and I think the family and the child need some support. Like the child is missing his school, so school support is also needed for the child.
so the mother mentioned that the child is spending a lot of time at home. His behavior has changed with the siblings as well because of that.
So so psychological counseling may be needed for the mother and the child, and
Mm-hmm.
maybe it might be it is a red flag sign, so we may need MRI to the child.
Okay. Okay. So how would you like to manage?
So first I will try to involve my consultant and I will do the appropriate investigations like we have to rule out the danger signs like any rise in intracranial tension, like any brain tumors like that. If everything is normal, we will prescribe the just anti-inflammatory agent like NSAIDs will be enough for this child.
Okay. Okay, but the child is already taking medicines and it's not getting better. So what else?
So if it is a migraine, we will give sumatriptan medications by consulting with my team.
Okay, so did you find any triggers regarding the migraine in this child? Because
Mm,
like migraine always has some triggers. So did you find any triggers?
I think no, ma'am. No, Ara.
No triggers. Okay, but the mother did mention that the child is having a lot of screen time. He's staying at home, watching TV, playing games. Do you think that can be an issue?
Like, we have to do the visual assessment of the child also.
Yeah, but do you think that like seeing a lot of screen time and that at night, could it be a cause? Like maybe the child is not sleeping well
Yes, yes,
and
ma'am. This might be also a cause of headache. So
mm-hmm.
stress headache.
Okay. Okay. So how can you help the child in school? Like about the missing school? Because it's not normal to just of a child to just keep on missing the school.
I don't know, ma'am. I don't remember
Okay. Okay. Do you think there's a
what to do.
need of psychologist in here?
Yes, ma'am. I think
How
psychology need psychology.
how can that like how can psychologist help in this child?
So we have to reduce the screen time to the child, and we have to maintain the quiet room for the child to during the sleep,
Mm-hmm. Okay. Okay. So the
and
time's
ask him
almost
to
up.
take
So
plenty
let's
of
just wrap it
water.
up. Yeah, that's good. Okay. Okay, so okay, very well done, Dr. Dasagir. I'm really glad that you attempted it. So it takes a lot of courage to just come up. Do not be upset. Like if I tell you a lot of mistakes, do not be upset with that. Okay, that's only because we want to learn and we want to do everything in a best manner. Okay.
Okay.
So for the first time, if you're doing it for the first time, it's a good approach that you have done. At least whatever I've taught you, I think you have done that very well. Okay, so someone has written in the group chat that it is a tension headache. Someone has mentioned that it is SOL craniopharyngioma. Okay. So, okay. So if I tell you that this is one of the recalls, it came, I think, in the 2024 second, right? Yeah. So the case was like that. And okay. Yeah. Case was like that, and similar thing happened. The similar presentation was being given outside the station that the child is 13 years old. Is I think probably 14, 13 years old, and he has height which is like low, and he had these things. Okay, one of the important, like I'm gonna tell you one by one that. Uh, okay, so I'm just thinking. Also, someone has mentioned medicine induced. Yes, we're going to discuss all of these type of headaches here. Okay, so I think first, I'll just mention that what issues were there, what could be improved, and then we could just discuss like the presentation and the theory that we want to do. Okay. One of the very key things that you missed in the history was about the past history. You asked me that past history about like any of the similar headaches in the past. Okay, I think you mentioned that in the past, but as I told you that you have to ask about the past medical and the surgical history, which would mean that any of the complications, any of the admissions in the past. If you would have asked me about that, I would have told you, like I'm telling you about the real case, like the real history that was in the exam. Was that whoever asked previously, the mother told, like I would have told you that the child used to have recurrent urinary tract infections in the beginning of the life, and for that he had some procedure, some renal procedure at the age of 4 years, and he remained on the follow-up of the nephro team, and then he was okay. Okay. So then you should have asked me about the renal symptoms and the blood pressure. Blood pressure was really, really important to us. Okay. So some things that were really important. Okay. First, I tell you that this history was basically the important points in the real case were that 13 years old child who was small, who's having headaches, who is small, but his small is not like really being fit into anything. The mother did give history of the recurrent UTIs on the follow-up of an ephro team and some procedure done. But then again, he said that he was like discharged from the follow-up and now there's no kidney issue. Okay. So headache is not due to that. The BP remains normal as well. Along with that, she does mention about his normal behavior of staying at home and watching a lot of TV. So basically, what they said is that it is a tension headache. The discussion happened that it's a like tension headache or the psychogenic headache. Okay. And it is being aggravated because of the excessive screen use. Okay. So this was basically how the actual scenario went like. And in this cases, they did ask about like whoever took the details of the screen time, how much screen time, and how much sleep does he take, and what does he watch on the screen, and told the management about the screen and everything. They were like given the full marks. Okay. But those who did not dig deep into the screen issues, because the thing was this, as I told you earlier, that in the history, things are not very simple. It's not that they're going to give you something like ready to cook, like ready to eat on plate, so that you just have to digest. You have to struggle through the history to find your cause. So in this history, practically growth, like small height, it was a distractor. It was taking you in some other way. The renal issue, if you would have asked, like I would have told you, it was a distractor. It was again not the cause. The real thing was about the poor sleep hygiene and the tension headache. Along with that, due to that, the child was feeling dizzy in the mornings. He was not going to schools, and then due to that, like his short height, he was having the peer pressure, he was having the issues of bullying or things like that at home, at school, and due to that he was like being just isolated, not having a good social life, right? So these things were there. Okay, so this was about the real case. Coming to your history, that what points I felt, um it's not something I'm sure that it's not specifically targeting you, so do not feel bad, do not feel discouraged. Okay, it's just for the learning of everyone. Few important things are that multiple questions at one time. I think all of the systemic review, I told you that you do not have to. I understand that I just told you and I just um mentioned and taught you all of those things, so it came out naturally in front, like from your mouth, to ask all of these one together. Once you start into the practice and it becomes your habit, you will definitely know that what question how to ask. Okay, so again, multiple questions at time, I think we should always avoid that. One question at a time should be the right approach. I think your DDs were very nice. The good thing was that your DDs, you had good DDs in your mind. I was really impressed when you asked about the severity of the headache while bending down or coughing, ruling out idiopathic intracranial hypertension, or ruling out the fever for any meningitis. And I think you asked, like, did you try to rule out the migraine as well, and analgesia headache as well? So DDs were okay. Then initially in the first few minutes, I did not feel any empathy, but later on you did brought that. Um, then history got a bit random when we went come to the past and the development or all of those things. It got a bit random. Avoid asking negative question that, like, you ask that he doesn't have any vision issues, right? We don't ask like that. We don't ask negative questions. We like, does he have any visual issues? Does he wear any glasses? Okay, so we do things like that. Okay, so just this is a
Okay.
general thing, but I do appreciate that you like survived this 22 minutes and you did well. So we'll keep on practicing, and hopefully with the time you are gonna get pro at all of this. Okay. So does anyone of have any comments, anything about this? And then we just wanna go through the theory and the presentation. Any comments or anything who wants to give about how anything that feels like that what would have been asked, or what any comments about the history or any questions about the history? Okay. If not, then we'll move. Okay, so this was the our role. Okay. So our first thing was to enumerate the problems in the chronological order, the presenting complaints. Then again, I think you did ask about the onset, you did about the duration, the pattern, daytime, number of days of week was important, that how frequency, like the mother told that it has become frequent for a few weeks. You needed to like know that how frequent. Okay. And then the details of the headache, you did ask about the throbbing and things like that. And between, I felt that some of the words were like maybe about throbbing in nature, or I think you used another word that I can't remember. But I think one of the two, a few words were like a bit complicated. So maybe you need to be a bit simple when asking. You just ask about the site and the severity, progression. Okay. So there's a mnemonic that we call STAR. For any pain, ask STAR. Okay. I know there's a lot of mnemonics. It's just for revision and like if you want to use that. S is for severity and site. T is for type and timing. A is for the associated features, and R is for the A is the associated features and the aggravating factors. R is for the relieving factors and the radiation. Okay. So you can use that for the pain. Associate features rule out the diagnosis. Okay, yeah. So for that, I think when you ask for the neuro, I think it would have been it should have been asked in a lot of detail. I think you asked all of the neuro things in one go, about the loss of consciousness, about the fits, about the psychiatric. I think it needed a lot more time and attention. So in the history of headache, you have to ask about the alternation, the sensorium, drowsiness, low GCS. Asking about the seizure is really important. Persistent vomiting is important. New visual symptoms like diplopia, abnormal eye movements, visual impairment, that is important. History of aura, behavior change, recent change in the gait, balance, coordination, any neurological symptoms, any recent head trauma is really important. And then about the systemic symptoms, about the rest of the systemic symptoms. Then relieving like the relieving features, the aggravating factors, the relieving factors, triggers changing with the bending. You did ask about that. You did ask about the progression. Investigations, I think you asked about the management, maybe not the investigations. That is there any workup done for this? Impact on the daily activity and the functional class. I think this had to be probed more. I told you on my own that he's missing school and everything. It needed to be like asked in a bit more of a detail. Current status of how many, if you were having analgesia headache in your mind, it's important to check that which medicine and how many days per week, because I'm going to tell you later on, like when I'm going to discuss about what the analgesia headache is. So it needs to be known that for how many days per week or a month a child is taking analgesia or the pain medication to like categorize that it is the analgesia. Then systemic review, I think you did that well. But again, not no multiple questions, okay? Past history of such headaches was important, but past medical and surgical history, any admissions, any other diseases, that was important as well. Pivotal history, development, you did well. Family, yes, you did that well. Birth history, I think it was okay. Immunization, nutrition, you did ask about that. Allergies, I think maybe you did miss that. Social, I think social you did not, like I think when you almost said that I'm over, I think a lot of social things were to be done. So social impact on the play, school, social factors leading to headache. What are his grades in school? Is he having an exam? How is he as a student? Does he have like boyfriend and girlfriend, but does he have any friends? And for how long this behavioral changes? Whenever there's a thing which comes up, you have to ask the detail of that. Like if I told you that his behavior is changing, then it was important to ask that for how long the behavior is changing, right? So it needed to be dig up in the detail. Parents understanding of the disease, the biggest concern and the misconceptions, and the head assessment, if any of this. I think all of this is important. Okay, so I've just write a relatively just a summary. It's not exact, not covering all of the things, but let me tell you that how a summary should be. Today, I spoke to Mrs. Anna, mother of 13 years old Adam, who has complained of headache for last 6 months and has worsened over last few weeks. It is moderate in intensity, having grade of 6 by 10, having no particular site. At times, it is preceded by aura and associated with nausea. It is worsened by improper sleep and relieved by taking painkillers. There is no association with vomiting, fits, weakness of any body part, visual disturbance, ear pain, or dental pain. Adam has a history of recurrent UTI in the early age and remained on follow-up of nephrology team and has a minor procedure, but no history of hypertension is present. He has excessive use of screen at night time. He's small in his class and has issues with in interacting with the peers, so he spends most of the time at home. Some obviously the ending part is missing, but this is how it should be. Okay. Okay. So about the headaches. Headaches can be classified into primary, intrinsic to the nervous system, or secondary. Just give me a second, and then we'll start with this. Okay, so headaches can be classified as primary, intrinsic to the nervous system, or the secondary, which are due to any underlying cause. So primary include all of these like tension headache, the cluster headaches, the migraine types. The most common primary headaches in children are migraine and the tension type headache. Viral illnesses are the most common cause of secondary headaches in children, while less common but serious causes include the CNS infection, including the meningitis, encephalitis, raised intracranial pressure, and the hemorrhage. Okay, so in ruling out infections are important as well. Whenever the child is having headache, you need to know if the child is having any dental infection, any sinusitis, any recurrent rhinorrhea, any ear pain, any of the face pains that could radiate to the head and that can mimic as a headache. Okay, so that has to be ruled out as well. So primary headaches. We'll read that one by one. Yeah. So tension type headache, it can occur at all ages. Usually it's bilateral, like involving all of the head, but it in the children, it's not really necessary that they're gonna give you a typical right one. Okay. So it could be like on different parts, like you can see here. Okay, we can see that and let's go horizontally. So in tension types is all ages. Migraine is all ages. Cluster headache is usually more than 12 years of age. Pain is in tension type is bilateral. It could be unilateral or bilateral. Here it is usually unilateral, offer around the eyes, which is associated with the vision disturbance, with like uh, lacrimation from the eyes, watering, and very very severe kind of pain. Uh, Here it is the pain quality is pressing, tightening, non-pulsatile. It is usually pulsatile, but again, for the children, obviously, the child cannot really tell very well if like if it's pulsating or not. So maybe do not find a similar word exactly. In the cluster headed, it could be variable, sharp, burning, throbbing, or tightening. In tension type is mild to moderate. This is moderate to severe, and this is severe to very severe. It is chronic non-progressive headache pattern, acute recurrent pattern. Okay. So effect on activities not exacerbated by activity. It is aggravated by normal activities, can cause restlessness and agitation. Associated symptom, there can be no associated symptoms, but they may be precipitated by significant stress, that emotional distress, poor sleep, missed meals. This is associated with nausea, vomiting, photophobia, phonophobia. It could be with aura, with the presence of focal neurological symptoms, usually visual, sensory, speech changes before the onset of the headache. Autonomic symptoms can be present in the cases of cluster headache, which it could be ipsilateral conjunctival injection, tearing, rhinorrhea, eyelid swelling, facial sweating, meiosis, or ptosis. Duration here can be hour to days. It may only last for 30 minutes in young children, up to 72 hours in adolescents, and this is for minutes to a few hours. Okay. So in the past, many time history has come for the migraine and the tension. Cluster I have not seen in the recalls much. The secondary headache, the causes, you have to rule that out. Okay. Even if you're thinking that's a primary cause, usually headaches are of primary cause in the history, but then again, you have to rule out any sinusitis, pharyngitis, acute otitis media, meningitis, encephalitis, abscess, dental caries, any head injury or trauma, raised ICP, which could be due to intracranial hypertension, IH, hydrocephalus, intracranial neoplasms, other intracranial malformations. It could be related with the intracranial hemorrhage. It could be substance use or the withdrawal, medication overuse. It could be psychiatric disorders, including anxiety, depression, somatization, somatization disorders, increased psychosocial stressors. These are really important. Okay. And so you need to know that what are any of these issues present. Okay, so you need to know, like, if there were family issues, the family history, you need to know that how's the like overall environment at home, like any stressors at home, any issues going on at home which could affect the child. Okay, so these are the headache guidelines. We're gonna go through them, and after the class, I want all of you to go through the headache guidelines, the book that I've told you. Okay, I hope all of you have those book in your uh like PDFs. Okay, so some things are the revision of what I've already told you, but like these guidelines, they have to be gone through. So the causes that we have already seen. Which book? Someone is asking which book. It is Bedside Pediatric Guidelines 2022 to 2024. Okay. Um, Again, yeah. So viral illness, ENT infections, minor head trauma, primary headache, migraine, tension type headache, neurological conditions presenting with headache needing the urgent attention. Okay, so you need to know why, because if the headache is due to any of these causes, you have to tell it in your management that this needs immediate management, immediate something intervention. Anything, if there's fever, there's symptoms of meningitis, intracranial hemorrhage, if it is related to shunt, if it is idiopathic intracranial hypertension, new hydrocephalus, brain tumor, brain abscess. If features of any of these things are present, then you have to like refer the child early and do the management early. Assessment. Okay, they have given a mnemonic here. If you feel like you can use that, otherwise, I think what we have done already would be good enough to cover all of these points. But they've written it as liquid 4. Location, intensity, quality, duration, frequency, other symptoms like nausea, vomiting, photophobia, dizziness, effect and degree of impairment due to headache. Associated symptoms already discussed: alteration, seizure, persistent vomiting, new visual symptoms, behavioral changes, recent changes in gait, balance, coordination, neurological symptoms, head trauma, systemic symptoms. Okay, red flags. This is really, really important. Remembering the red flags is really important. This is going to help you. You have to ask them in the history as well. You have to tell them in the summary as well that the child has red flags or not, because your management depends, your investigation management depends a lot on this. So let's go through this red flags. Recent onset of severe headache, like child has recently started headache for a few days and it's really severe. Change in the headache severity with frequency, like in this child there was frequency was increased. Early morning waking from sleep, like whenever there's a headache or any of the problem, always ask that is the pain severe enough that it like wakes the child up at night, right? If the child is getting like being waking up at night due to the pain, it means it's really, really severe. Postural headache, as he like I think Dr. Dastagir asked, that it is meant like on bending or on coughing. Fixed or unusual location, like if it is the pain is located only at one side, like on the back of the head, on the side of the head, it's on only one side, that is a danger sign as well. Ophthalmological signs and symptoms, especially new onset, like as I mentioned, any like visual issues, any ptosis, any of the other things associated with the vision. Abnormal growth or puberty, deterioration in the school, work, personality. So see, the child was not going to school. We have to ask about that as well, and parental worry. So you see, if the parent is very, very worried and something like that, like if the child, like mother could say that there's a history of tumors in the family and I'm really upset that my child could have similar things, then again, you have to consider that as a red flag. Be cautious of first and the worst headache, short history of progressively worse headache. Okay. Now, moving to the examination that you would do. General physical examination will see if the child is having fever, skin rash. In this child, like weight, height, plotting them on chart was important as well. Abnormal head position, torticollis. You have to like tell that you are gonna see this. Okay, why skin rash? Because the child could be a case of neurofibromatosis and having some skin rashes or some hypo like cafe or macule spots, and it could have neurofibromas in brain. Then marker of neurocutaneous syndromes. Neurocutaneous syndromes are very, very important for these exams. Neurofibromatosis, tuberous sclerosis. Okay, so you have to remember them well. BP, pulse, oxygen saturation, temperature, weight, height. BMI is important. Why? Because when we're going to see that idiopathic intracranial hypertension, that is related with the obesity, high BMI, pubertal status, scalp, face, neck, oral cavity. Full ENT examination is required. Then the neurological examination, especially look for the new onset of squint, cranial nerve palsies, any other focal neurological deficits, cerebellar signs, including nystagmus. So you have to tell it about CNS. So you have to tell the neurological examination all in detail. Cerebellar signs, nystagmus, meningeal signs, fundus, if uncertain or abnormal, discuss with ophthalmologist, right? Imaging, investigations and management based on the clinically suspected cause of headache, MRI brain, if contraindication to MRI, then CT. Okay, so indications of imaging. This is important as well. It should be on your questioning and in your management plan. So if there are any red flags present and headache is difficult to classify into one of the primary headaches, for example, migraine or tension type, so you have to do MRI. First or the worst headache of life, short history of the progressively worse headache, presence of new neurological signs and symptoms associated with the headache, which could include persistent or recurrent vomiting, balance coordination problems, abnormal eye movements, behavior change, seizures, abnormal head position, head tilt. Okay. So you see the like they mentioned particular lethargy. The child was lethargic as well. So we could have gone for the imaging. So indication mostly are about the red flags and the few other things. So you need to remember these as well. Okay, I think yeah, this is about I think we have done all this. This is all what we have done. Okay. From I took some points from the nice guidelines as well. You can read in them in detail on on the website. So headaches, if they are in the children less than 12 years of age, refer immediately children under 12 years age with headache for the same day assessment according to the local pathways if they have one of the following. Okay. So just an idea, if the headache is severe enough that wakes the children at night, headache that is present on awakening in the morning, headache progressively worsens, headache triggered or aggravated by coughing, sneezing, or bending down, fever associated with fever, features of meningism, vomiting, ataxia, conscious level, lethargy, headache occurring within 5 days of a head injury, headache associated with the squint of the failure. So basically, it's about occurring of any neurological signs and severity is high. It's causing early morning because that indicates some SOL or high pressure in the brain. In less than 4 years, refer all the children under 4 years urgently with headache for the neurological assessment. Why? Because the primary headaches are less likely to occur below 4 years of age. So if a child below 4 years of age is complaining of headache, you have to refer to the neurology. Other than that, you can like depending upon the other features. So a little bit about all of the headaches, the primary headaches that we discussed. Tension type headache. Common symptoms of tension headache includes pain on both sides of your head, face, or neck. Feels like something is pressing on your head and being tightened around it. The affected area may feel tender, and your head may hurt more when touched. Tension headaches last at least 30 minutes, but they can last much longer, sometimes for several days. Common causes are stress, sleep problems, caffeine. So basically, in this child, it was like a variant of something with tension headache because the child was like watching a lot of TV and screen and not sleeping well at night. Other things were distractors in this specific case and in this specific history. Tension type headache, you for the management use painkillers like paracetamol, aspirin, and ibuprofen. Paracetamol is the first choice of painkiller if you are pregnant and children under 16 should not take aspirin. Try doing activities to help you relax like exercise, yoga, or massage. Try changing your sleeping habits if sleep problems like insomnia may be causing a headache. In this one, I remember that some candidates told that they did ask about the sleep hygiene. How would you improve that? How can you help the child with that? How would you counsel that? Try using a low, firm pillow or heat or cold packs if you have neck pain and headaches. Try to stay at home, avoid contact with people if you have a high temperature or you do not feel well enough to go to your normal activities. Okay. So tension type headache. So if I tell you that for this specific case, the investigations could be that I would like maybe you were right that there were not a lot of danger signs, but you can say that I will discuss this with my consultant and see that if the MRI has to be done. Okay. This thing other than that, maybe the child did not have any vision issues, but you can always say that I'll get a visual assessment done to see if that is there and issues regarding with that. Also regarding the short stature, you could have tell that like plotting the child like height in the centile charts, looking at the BP, all of those things would have been important. Regarding the management, the first thing would be like the reassurance, because your first differential is the tension headache, like the sarcogenic headache. So you would say that the reassurance, improving the sleep hygiene, okay, in which you will tell that stop the usage of phone at night, all of those things. This child is having behavioral issues as well, okay. So in this typical history, the involvement of a psychologist would, it's really important to see that is because the child has is being bullied at school for the short height, so that has to be maintained. The child needs to go out, have a good peer interaction. So for that, psychologists may have to be have the school authorities have to be taken under the loop as well, because he's being bullied at school, okay. Those things, maybe the family counseling as a whole, to have like overall improvement at home and involving him in all the activities, okay. So the discussion was mostly about all of these things. Cluster headache, it's less common below 12 as I discussed, but as a brief overview, there are severe headaches that can happen multiple times a day and continue for weeks or months. They may stop for a while, weeks, months, or years, or there may be no gap between the headaches. And the main symptoms of a clustered headache include a sharp burning or the piercing pain, usually on one side of the head, around the eye, headaches that happen at the same time of the year or at the same set times of the day, headaches that start and stop quickly without warning, pain that can make you feel restless, may want to walk around or move your body, headache that lasts between 15 minutes to 3 hours. There's no cure for the clustered headaches typically, but a specialist may recommend treatments to help ease and prevent the symptoms. Painkillers like paracetamol and ibuprofen, they do not usually work. So what you can do is that if it started, you like can use the triptans as an injection or nasal spray. Oxygen can be given, and there are other devices as well. Again, I'm telling you that these, like, you might not be asked all of these treatment at this very level. It would be like, I'm telling you that in the yesterday I took all of the thing. You just maybe have to tell about that what reassurance journal merges that you will take. Okay, so don't, even if you're not remembering the name of the drugs, you can simply say painkiller, right? So don't exhaust your energy and your stamina and all of those things in remembering the names of a lot of drugs, their doses, or things like that. Focus on, like, discuss whenever you're practicing with your friends, try giving the scenarios which are difficult to manage as a case, right? And not difficult, not in the sense of what medicines would you give, medicine like what different challenges, like try whenever you're practicing, try giving different kinds of challenges, like social challenges, like some psychological challenges. For that, when the management would be told, that would like help you polish your skills, okay. Because you see that like the discussion I was having yesterday, the thing is that obviously RCPCH know that a lot of candidates, like, they are taking courses and everything, okay. We are here to help you, but we do not want you to like copy whatever we tell you. Like, as I told you that the lines that I told you, Dr. Dastagir, they are just sample lines. I do not want you to use these typical lines. I want you to make your own lines, be spontaneous, come up with your own ideas, your own management plans, okay. Do not try to, as like, if you are 20 students right now, I don't want 20 of you to go to the exam and say the similar lines, right, which would give a bad impression. I want you guys to have like your own approach. Each one of you is different. Each one of you have a different style of communication. Inculcate that in your history, in your communication, and that's going to help you in the exam. I truly believe that. From okay. So migraine, it's throbbing pain on one side of the body, or like on one side of the brain head. Aura, it could be like flashing lights, tingling, difficulty speaking, feeling dizzy. It usually lasts between 2 hours and 3 days, with some symptoms such as feeling very tired, starting up to 2 days before the head pain starts and finishing after the headache stops. The triggers, you have to, like, if you are thinking about migraine, you have to ask about the triggers, like illness, poor sleep, exercise, menstruation, stress, heat, sun glare, foods like citrus, MSG, artificial sweeteners, nuts, onion, salty food, caffeine, chocolate, skipped meals, missed medication, or medication overuse. Okay, so if you are thinking there's a typical history of migraine, then do remember to rule out all the triggers. Then, for the management of migraine, the important thing is reassurance. Food and the headache diary, like tell them that to maintain that, to know that what food aggravates that. Lifestyle and dietary advice, very, very important. Possible triggers have to be taken care of. Pharmacotherapy could be like a respiratory prophylaxis and anti-migraine diet. During the if there's an episode going on of migraine, journal measures, encouraging your child to relax and breathe deeply, putting a cool, moist cloth around the forehead or eyes, lying them down in a cool, dark, quiet room. Paracetamol and ibuprofen are generally best, if not improving, then sumatriptan. For preventing the episodes, you need to go down to bed early, not use tablets, phones, computers, watch TV in bed. If the headache might be caused by skipping meals and not drinking enough, make sure that you have a water bottle at school, eat something every meal time. So whatever trigger is found in your history, you need to address that. Improve diet by avoiding processed sugar, cut down processed food or drinks, etc. If stress and anxiety could be the cause, try to speak to your child about what's worrying them and speak to staff at the school. So you need to ask about the like his performance at school, his grades, how anxious is it, how is he a good student or not, like overall his anxiety levels are like this. Limit screen time to more than a couple of hours a day and make sure they take breaks every half hour if loud music or screen time could be a cause. Simple analgesics to less than 15 days per month and triptans to less than 10 days per month. Okay, another very important cause, a very common history coming in is the idiopathic intracranial hypertension. Um, this is again from the guidelines. Suspect IIH presenting with papilledema with or without sixth cranial of palsy causing diplopia, intact conscious levels with any pattern of headache. So intracranial hypertension, it could present with any type of headache. It could have like normal conscious level, or it could like present with a sixth cranial of palsy or with a diplopia. Features of raised intracranial pressure would be nausea and vomiting, and headache, which is worse lying down, coughing, bending, or doing some exercise. Additional features, child waking up in sleep with headache, pulsatile tinnitus, dizziness, ataxia, back or neck pain or stiffness. Common visual symptoms could be that transient visual loss or blurring of vision, request ophthalmologist to confirm papilledema, obtain color vision and visual field charting. So if you are like if we are suspecting, there has been a recall in the past in which there was a obese child, there was a obese kid and female, and she was taking oral contraceptive pills and which led to the idiopathic intracranial hypertension. So whenever you're dealing with that, in that you have to get like this ophthalmology, papilledema checked, color vision done. All of this would come in your investigations. Um, Causes, as written here, these are important to remember. It could be obesity, usually associated, or the risk factor. Drugs may be a cause or contributive factor. For example, steroid therapy or withdrawal, growth hormone, tetracyclines, OCPs. OCPs are really important. Endocrine causes could be hypohyperthyroidism, hyperparathyroidism, adrenal insufficiency, or Cushing syndrome. Hematological could be iron deficiency anemia or sickle cell anemia. Infections and systemic disorders could be otitis media, Lyme disease, HIV, chronic renal failure or SLE, obstructive sleep apnea, cerebral venous thrombosis. Any of these could be. So mostly in the history that I've seen is obesity, drugs, and at times endocrine causes. Investigations that you have to do: initial full blood count, bone profile, TFTs, urea electrolytes, parathyroid hormone, others as clinically indicated. MRI imaging, MRI brain is a modality of choice. CT only if there's any contraindication to MRI, and you have to urgently done an imaging. MRV could be done if needed, and like a radiologist advised. LP. Lumbar puncture is done. It is both diagnostic and therapeutic. If the opening pressure is more than 28 centimeter of water, normal cell count and biochemistry would be normal. CSF pressure can be falsely high or low. Hyperventilation can reduce the pressure, uh, which means that it could be like wrong reading. Distress, anxiety, whatsoever can increase pressure. So these things can be like false positive or false negative. LP can be performed under analgesia, sedation, or general static, which increase the pressure. And tidal CO2 should be monitored and kept in normal range for LP under the general aesthetic. So you don't have to remember all of these things. Just remember that whenever there's a child with idiopathic intracranial hypertension, you have to go for like maybe lumbar puncture. The treatment is starting the acetazolamide. They've written at the end, be careful about child with papilledema suspected on routine eye check in an asymptomatic child. Seek advice before starting the investigations. Do not diagnose IIH on high CSF pressure alone in the absence of the clinical features. So it's not just that there's high pressure, then you're gonna miss that. You have to have proper clinical features, right? So idiopathic intracranial hypertension, again, a very important one for your history station. Analgesia headache, this can be asked like in the DDs. Medication overuse affects approximately 2% of the world's population. It can turn an episodic headache into a chronic daily headache or worsen an already existing daily headache in approximately 3 consecutive months of overuse. So there's a criteria for analgesia headache that you have been using like analgesia medicines for more than 3 consecutive months. Any painkiller can produce this effect, such as paracetamol, ibuprofen, Panadol, Anodine extra, Codamol extra used more than 15 days per month. So what happens? The criteria is that you're taking any of these medicines for more than 15 days per month for 3 consecutive months, right? But it happens quicker with the codeine or opiate-based drugs or with the trypsin. Like these are the low analgesia drugs. The second class, the severe, like the more hypotensive drugs, they are for the 10 days. So if you are using any of the opiate-based or the codeine drugs for more than 10 days, for 3 consecutive months, you can have the analgesia headache. This includes all painkillers you buy yourself. Like any of the painkillers can cause this analgesia dependency if they have been used very, very frequently. So what do you have to do? Like management of analgesia headache. Stop all analgesics for 8 weeks unless on high dose opiates, in which case you will be advised by your physician how quickly to reduce this. Like that cannot be reduced like fully at once. And the withdrawal includes all your painkillers and triptans, regardless of why you take them, and includes both the prescribed and the painkillers you buy yourself. Look at alternative pain relief such as ice packs, heat packs, massage, anti-inflammatory gels, forehead sticks, or alternative therapy like acupuncture. Aim for a healthy lifestyle, including 3 meals per day, liters of non-caffeinated fluid, sleep, exercise, stress, or like all the journal things that you have to tell. If there's nausea, vomiting become an issue, during the withdrawal, you can get an anti-sickness tablet, providing you have no contraindications to using these as significant heart arrhythmias. Get support from friends, family to make life easy as possible during this time. Help with housework, shopping, childcare can reduce your stress levels, like any of the other things that can distract you. At times, the preventive drugs could be used. However, these take at least 4 months to be effective once the therapeutic dose is reached. And then like you don't have to like read all of these, just to know, because there isn't a history in which they have asked this. I just mentioned it in detail so you can just have a read on this. So in short, whenever there's a headache, primary headache is considered. Whatever you're thinking, take detailed history of that very thing. Rule out the other causes, rule out the secondary causes. Okay, so in the recalls, if I tell you, I've seen the histories of this tension headache, migraine headache, and idiopathic intracranial hypertension, which have like been coming off and on. Okay, I'll try putting. I haven't like I forgot to put the previous recall statements in this presentation. I'll get them in the next one, like the second part that we're gonna do for the CNS. I'm gonna mention all the previous recalls of the CNS histories in that one. Okay. So I think with this we come to end of today's class. Any comments, any questions, anything that you guys want to ask or say?
Ma'am, also try to keep the recalls of this headache in the group, ma'am.
Mm, okay. I think there have been files of recalls overall system wise. I'm gonna put them in my slide, and then they will have the recalls of the headache as well. I'm gonna do that. Okay. Okay.
Thank,
No questions, nothing. I do feel that you should have some questions. Okay. Okay, if no questions, can I have any of the comments of how the class was? What do you think? We see you, and we want you to be as active. We want to help you, and like we want to guide you throughout. So it's not that we have had a set pattern. We do have a pattern in our mind that we're going to follow, but it's your suggestions, your any of your like things that you want to mention are always welcome. We are always ready to change our things, our teaching according to what you guys want. So please do give in suggestions, do give in your feedbacks. They're gonna really, really be important to make our classes better. Anything that you think needs to be added to make things more better, or anything that you think needs to be done differently. Okay, so thank you so much everyone for joining in. And I hope that this is going to be a great learning for you and for me as well. And okay, if there are no other questions, then I think I'll be signing off for today. So again, announcing that we'll be having second session of the CNS histories on Tuesday at same time. So see you guys then. If you have any queries, anything that you feel like you have, like we have our group, you can discuss that. There's obviously a specified class group, but all of the others, we have a journal group as well of the 2025 like MedPrep group that we have, in which I usually I try to post regularly. So if you have any queries, do ask there as well. So thank you so much everyone for joining in. Have a very good night. See you on Tuesday. Bye-bye, everyone. Thank you, Dr. Kim, Dr. Nagam, everyone who's there. Next time, I'm going to have an introduction of all of you as well, and so that we can have more interaction and I can know more of you. Okay, so bye-bye. Thank you. See you guys.
Thank you, ma'am. Good night.
Good night.